Perfect. Hi guys that are here so far. Everybody's afraid to talk. Oh. Is anybody actually able to talk?
I can talk.
Can you hear me?
Okay, I just want to make sure I didn't screw something up and muted everybody and Hey, there's some faces. Hello. How's everybody doing today? Good talk.
I wish I could just sleep for days. That's how I feel.
Oh. Did you work last night?
No, but I work tonight. But
Oh.
I teach later on today, and
Oh, what are
it's
you
just been a.
what are you teaching?
I teach at USM.
Oh, okay.
Yeah, I teach nursing labs at USM. So today's my last class, so that'll be good anyway. But I just feel like it's been crazy lately. Everything your free time is. I feel like I don't have any free time. I'm always doing something, which
Yeah.
is weird because you can't do anything because of COVID.
Yeah.
Brett, just tear your labrum.
Yeah, exactly, Molly. Yeah.
Yeah, how are you doing? I didn't realize you were out for that.
I'm fine. I'm coming back soon. I just can't lift, so I think Sean has something up his sleeve for me. We'll see what
She's
it is.
milking it.
Anything's
Paperwork.
better. Shut up, Brittany. Anything's better than the COVID hotline. Just don't put me on the COVID hotline.
You're gonna be on the vaccine crew.
Hey, I'd rather do that. Poke people and just tell them to GTFO. I don't want to talk to anyone.
Bye.
So it seemed like there might be some more people coming, so I can give it a couple minutes. We can just casually chat. Feel free to put your mics, your cameras on and stuff. Like, you don't have to. And also, I highly, highly, highly recommend that you relax, get in your PJs, get your cocoa. I want to see cats and dogs. Maybe not little children, but just cats and dogs. And maybe fish. I don't know. But this whole experience is that I've always sort of envisioned. Ah, yes, there it is, right there. That is adorable. He needs to come to the unit, or she. Oh, and look at over. Oh yeah. Okay. This is gonna be a good session.
My other dog is getting a haircut right now, so hopefully she'll be back before this ends.
They can get that during the pandemic. They're allowed.
Apparently, yeah.
Okay.
You all
Bella, where's your dog?
Oh, and a
I'll go get her.
cat.
Morning from Norman and I. Thank you so much for doing this, Mark.
Oh yeah, no worries. My pleasure. Is that a cat now? Or is that? Oh, it's a cat and a dog. I mean, this is yes, yes. We got cats and another dog. Oh my God.
Yeah.
Oh my God. Okay. So when we actually get to meet in person and not have to do this by Zoom, which by the way, I do like Zoom just because I think it makes everything more accessible and stuff. But if we all get together, we all have to bring these together and I need to pet them and touch them and snuggle with them.
I can barely keep my plants alive, let alone like another living thing like a dog, cat, or human.
Oh.
Same, Britt. Same.
Well, let's see. We got what? 3, 6, 7, 8, 9. We got 9 people. So we can get started. I know obviously some of you were here one time before. I've only done this once before. Some of you are new. And so how I really want this to go is really just to be an organic experience. I don't have necessarily an agenda. So I like to just see how people are feeling. And then, if there's either a question or maybe even just sort of a concept, we can just start talking about things. Or, if people have questions about something specific. I love scenarios. And I always like to preface this whole thing with I don't have any special background. I don't have a degree in anything other than nursing. All my information just comes from experience. I do my best to give what I do know, and I do like to also let people know that this experience is not only for you people, but it's for myself as well, because already there are questions that I haven't been able to either answer or I don't feel satisfied with my answer. So that allows me to try to figure this out and also not leave it hanging. So just so people know, I've kind of had this idea that sort of came about after the first session, and that is, first off, I got to figure out if I actually know how to do this or can do this. But what I'd like to do is after our session, I've been writing down the questions that I feel like I either didn't know or wasn't satisfied, and I've gone to my resources to try to figure out those answers as best I can. And then I'd like to present it back to you so it's not just like unfinished business. And the best way I thought maybe I could do this is to maybe like we are doing now, but do a video to answer those questions and then post it in a YouTube form, and then people can come back. So I will do that. I already have 3 things that from the last session that I've been able to answer. A question that Britt brought up about citrate toxicity. There was a question about loops and thiazides and why do we use them together? Like, how does that actually work? And I brought up something that I know we do, and we just don't do it often. So I understand kind of what it's for, but I really don't understand what it's telling you or how it's telling you something. So I was able to kind of figure some of that stuff out. And so I like to present it, and I just figured, if people come to one but they don't come to the other, I don't want it to be lost information. So I figured I might be able to post it, and then people can just sort of come back and say, okay, we identified some of those questions. So I'm sure there's going to be questions today that maybe I don't really know how to answer, but like I said, I will do my best, and I want always this experience to be comfortable, relaxed, no stress, there's no beeping, there's no family, there's no alarms. Just take your time. And what's nice about this too is that there's all different levels of experience here. And so some people are brand new, some people are years down the road. Um, and so when one person asks a question, it might be from a very, very basic level because you're brand new, but then someone who's more experienced is asking questions that maybe that person would never have thought about right now. So it's great. It helps get the mind going, and and it's great to see like where people are at. So I guess everybody's feeling okay. How are people feeling right now? I mean, where are we at? I know life is hard and the pandemic is rough and we're all going through it. And so just like, where is everybody's mind at? Does anybody want to share anything or? Okay. It's okay if you don't. If you're shy and don't want to talk, don't worry. That's not a problem. Also, ask your questions because back in the day when you were young and you went to school and someone said, "I'm too afraid to ask that question." If one person has a question, there's got to be someone else in the room that's got that same question, and that other person's probably me, anyways. So everybody's doing okay. Just the general gist of things. Okay.
I know from like a new grad, literally just started my career as COVID hit the world. I know it's overwhelming, but I feel like really supported by almost everyone. The like overarching question I've had, and I wondered this yesterday, and you kind of talked about it before in your vent class, which was also really helpful. I think you have one that again tomorrow, right? Something like that.
The 15th. Next.
Nice. It's really great for everyone to attend. It was really helpful. Is the ARDSnet protocol in like the high PEEP? Like I get why you'd have increased PEEP, but like I see the chart that they do, and sometimes you're like in COVID, you're stuck in the room, so you help like RT like fix things, and you just like have to work collectively as a team. I don't get when they're like, you chuck up the PEEP really high and then you lower their O2 like first and then you work on the PEEP. I don't really understand it.
So it's a little difficult to speak to that only because as I'm not an RT, right? So I think I have a good handle on what's happening, but there's also a lot of other dynamics that I don't know. But when it comes to... Oh, sorry. I think that might be my speaker. Let me just bring it down a bit.
Path of ARDS with like the high PEEP settings.
Yeah, so I mean, we can start and talk about why those things happen in sequence. So, when you have ARDS, you have somebody who has obviously really bad lungs, and there's criteria to meet that diagnosis, right? So one is the PF ratio. One is bilateral infiltrates on imaging from a chest X-ray. One that we sort of don't do, but we kind of just look at somebody and say, yeah, no big deal. Like, most likely they're here for CHF of some sort. I mean, possibly, is just like a wedge pressure of greater than 18. But, we're not throwing swans in everybody. So we kind of, I think, identify those two aspects primarily. And then obviously the bigger picture when docs look at their patients. And so when you have those patients that are getting sicker and have that issue and fall into that criteria, we know that ventilation can be an issue, but really the oxygenation is a huge issue. And if you remember anything about VQ mismatch, you're thinking of your ventilation, and the Q in this instance is perfusion. And so when you have somebody in ARDS, their compliance is poor. They have neutrophils going throughout their body because they're in this pro-inflammatory state. And so they're vasodilated, they have neutrophils, those things get caught up in the lung, And then all of a sudden, all those cell mediation processes happen within that lung amongst everywhere else in the body. And, that causes injury to the lung. And there's capillary permeability happening there at the tissue level. And so what's interesting about the ARDS is that I always I'm going to sit sideways for a second. I always use this as, this is your alveoli, and this is the capillary bed. And there's basically such an expansion of water that separates these two areas. So when they're sitting here kind of cradled next to each other, air goes into the alveoli, right? And this is where gas exchange happens here. And then it goes into the capillary bed, right? So CO2 out, O2 in. But what happens is, as time goes on and you have this increase in this permeability and injury, you have water that's actually kind of leaking into these areas and actually separates. So kind of taking a different step to the left and back, when people are sick and septic, the first thing we always want to do is flog them with fluid. And we always talk about driving up people's CVPs and, making sure we have enough fluid and tanking them up so we have, room to add a pressor if need be. In these patients, one of the things that we want to do is actually kind of the opposite. You want to find that happy medium of giving them a blood pressure, not promoting more ischemia, but you want to actually diurese these patients to get some of this fluid off so that this isn't like this anymore. It's actually pushed back together, so there's better gas exchange. So the issue at hand is really an oxygenation problem primarily. And so we know what PEEP does, or do we need to go over PEEP again? Do we feel, I can't see all of you, but do we need to go over PEEP? Because to understand PEEP is to understand why these high levels of PEEP in these instances. And I'll keep going to your original question, but does PEEP, do we feel like we need to talk about that? What PEEP really is? Is that, I see 4 faces. So I'll just talk about it. How about that? We'll just talk about it. So, when we have PEEP, right, it's a pressure, right? We all know that it's a pressure, and everybody can recite the name of it, right? Positive end expiratory pressure. But pressure has to come from something. So there's a force acting upon something that's causing restriction. So in this instance, if we're talking about the lung and we're trying to talk about a pressure, well, hopefully what's in your lung is air, nothing else, right? We don't want blood, we don't want sand, we don't want, snow. We want air, right? So when we talk about the lung and we talk about pressures, we're talking about air. So positive end expiratory pressure is a pressure at the end of the exhalation phase without the tidal volume in, without that breath in. But that is comprised of air, right? So there's a volume of air that's left in your lung to generate that pressure. And when you think about how pressure is created, you need resistance, right? So I need some force to act upon to push back on, right? So in this instance, your lung, the tissue, is being stretched, right? And it wants to push back. So when the air goes in there, it's pushing back on that volume of air. And as the amount of air goes in your lung, the pressure rises. So think about like if you blow up a balloon, right? The balloon starts to stretch open, open, open. But if you were to put a little sensor in there, the more air you have in there, even though it's nice and stretchy, is going to increase the pressure. So 100 cc's versus 200 cc's versus 300 cc's is going to generate different pressures, right? So that's one aspect to think about. But then the other thing you have to take in consideration is that if the walls are really nice and soft and stretchy versus really, really rigid. So if those lungs are really rigid, those it's like more force pushed back on the same thing. So when I have 100 cc's of air that goes into a nice, soft, stretchy balloon, the pressure inside is probably not that high, right? But if I take the same sort of airspace and I make that wall, that balloon, kind of really rigid, that same amount of air that went into that rigid area is going to generate a lot more pressure. So the same volume will generate more pressure. So when we talk about PEEP, you have to think about the amount of volume it takes to generate the pressure, but then the compliance that's behind that. So if I want 5 for you and you and you, if you have the same nice stretchy lungs, well, based on the size of area, that volume will be different, but the 5 will be consistent, right? The pressure is the consistent thing, but the volume will not be the consistent thing. It will always be different. So when you have a stretchy lung and you want 5, probably a lot more air will go in there before you hit 5. But if you have a non-compliant kind of rigid lung, a little bit of air will go in there and just like immediately hit that same pressure, right? So that's kind of like the first thing. That's PEEP. And I mean, there's more to that. It goes into hemodynamics and all this other stuff. But the general concept of PEEP is that you are trapping air in their lung at all time, to generate that pressure. And if we're talking about the alveoli sac, and this must transfer over to what we're talking about is oxygenation, which is your problem with ARDS, which is your problem with a lot of things, right? So when you have somebody who is hypoxic and hypoxemic, so if you get a blood gas and their PaO2 is low, we want to maximize that. We want to increase that, right? So what can we do? What are the things on the ventilator that we know we can alter to increase one's oxygenation? Well, one obvious thing is FiO2, right? Dial that up, dial that down, and you go from 21 to 100. But we know that levels greater than 70 are considered toxic, and we can talk about that in a second if you want. But there's something else that we can do. So where is gas exchange occurring? Well, it's those alveoli, right? So O2 in, CO2 out. So the whole kind of concept behind the PEEP is to increase one's oxygenation through recruitment. So in just a general sick lung, forget ARDS, but just across the board, you have alveoli sacs that are working and functional and some that are not. And so the ones that are not, we call that atelectasis, right? So those things might be shut. We might have mucus in the way. So maybe they're open, but there's stuff in the way. Maybe there's water in the way. Maybe it's pulmonary edema. There's an assortment of reasons why one might be hypoxemic and then hypoxic, but at the alveoli, right? So if we utilize just FiO2, well, that doesn't do anything to the water, right? It doesn't do anything with the atelectasis. It just fills air spaces that are functioning with just more oxygen, which is okay, it's great. But then if it's not enough and you're at 70, 80, 90%, then what else can we do? Well, how about these guys that are stuck shut? So I always kind of use this analogy because I feel like everybody in their life has probably been part of a party at some point, and they have these like lovely, easy, stretchy balloons, and they go bloop. But then there's those little guys that just are so stubborn, and you're like, and you mean the veins popping out on your forehead, and then finally it pops open. Well, that's kind of how I relate PEEP, right? So if you increase the volume of air that you leave in the lung at all time, eventually you might pop open these guys that are not working right now. So you're maximizing surface area, you're increasing the amount of alveoli sacs that are able to help with gas exchange. So, primarily the O2, but also with ventilation, because CO2 does have to escape somewhere, right? So by increasing PEEP, you help to maximize oxygenation. But you have to recruit things, right? That's how you do this. So when it goes to your question about these higher PEEPs, well, you have in ARDS specifically, you have this issue with maybe non-functioning alveoli sacs to begin with, but ones that might be are also sort of, if you will, displaced. They're pulled apart from their capillary circuit. So there's maybe a good amount of air here that has a great amount of oxygen in it, and there's blood that's running by no problem, but they're too far away for any of this diffusion process to occur. So in that case, we need to sort of remove the water aspect of their lungs so that things come back together, and then better gas exchange can occur. CO2 can escape, but O2 can finally get in there. So when we look at patients who go into ARDS or just bad, pneumonia, whatever, but your question is to the ARDS, is to maximize oxygenation. So in all of these cases, right, we just talked about compliance. And so going back, take away the peak for just a second and think about the lung as a whole. We have a volume of air that has to go in for your breath and then come back out, right? In and out, in and out. So if you take that whole concept of the compliance issue, soft lungs, stretchy lungs versus really rigid lungs, if you take the same volume of air as a tidal volume and you put it in their lung, if they have the nice stretch, the pressure is probably not going to be that high. It's going to be good. But if I continue that same volume, just use an example 500, and I now have a non-compliant lung or worsening compliance, so now I have airway pressures that are higher and higher and higher, and it's getting more and more rigid. That same 500 is going to generate a way higher pressure because it's the walls are so rigid, they're not really stretching, so they're resisting even more. So if you don't sort of fix that, left that untreated, we worry about barotrauma, baro referring to pressure, right? So we don't want to pop the lung and give them the fancy pneumothorax. It's called barotrauma in this case. That would lead to tension pneumothorax, which would then lead to PEA arrest. So we don't want that to happen. So when we see airway pressures getting higher and higher and higher, as we do in ARDS type patients when their compliance gets poor, and other like pneumonia, all these other processes, then the compliance gets poor. We have to protect their lung. So to do that, and taking in the ARDS-NET protocol, we have to protect the lungs. So the best way to do that in this instance, if we're taking this CMV type process, is we drop the tidal volume, right? We don't want to put 500 in anymore, because if we do, it's gonna pop. Something's gonna let go, and the area that's weakest will be the area that pops. So how can we fix that? How can we protect them? Well, don't put 500 in anymore. But if you don't put 500 in anymore, you're losing the end product here, and that's your minute ventilation. So how I've always equated the minute ventilation is, everybody always has a handle on cardiac output. We all know this equation, right? We all know that heart rate times, anybody? Stroke volume. I know you're just too shy and you haven't had enough coffee, just like me. But heart rate times stroke volume equals cardiac output, and we talk about that as liters per minute, right? So I think a lot of people have this understanding, especially if you're fresh out of nursing school. I feel like we know this a lot because I think we talk about it a lot. But we don't talk a lot about ventilator stuff because it's not a primary nursing thing, right? It's an ICU kind of thing. So not everybody's leaving nursing school to be an ICU nurse. So you don't really need to talk too much about it. But minute ventilation is like the cardiac output, but of your lung. So it's just called something different. It's liters per minute, and it's still a rate and a time. So in the heart world, we talk about heart rate and stroke volume. In the lung world, hopefully not blood, it's air, right? So we talk about respiratory rate, and we talk about tidal volume. And that equals your minute ventilation. So one's minute ventilation, the number, arbitrary. It doesn't mean crap. Okay, if you're healthy, sure, there's these standard numbers, right? But what you have to think about is when you have a patient in front of you and they're really, really sick, maybe they're just at the start of their sepsis and whatnot, you know, we know what that looks like, I hope, and if not, we can go and talk about this next. But we know that they have a loss in their bicarb, they're trying to blow off CO2, you know, they look terrible, they have a lactic acidosis, all these other processes are going on, and they're chugging along, and we're trying to correct, or we're trying to compensate, maybe not fully correct, in fact, we don't usually fully correct, which is fine, but we're trying to compensate respiratory for the metabolic process that's occurring, right? So we have to usually breathe faster for them. So that right there will give you a pH, right? That will change your pH. If I breathe faster, if I breathe slower. So when you look at someone's minute ventilation, if you were to look at a blood gas that was sort of happening around that time, either exactly at the time or, you know, maybe 4, 5, 6 hours ago, and nothing's really changed about this patient, then let's just say, as an example, their minute ventilation was 740, and they had a they had a pH of 740, and their minute ventilation was about 10 liters. Then I know that in order for them to maintain 740, they have to breathe in and out 10 liters, right, per minute. So if I have a non-compliant lung and I need to take away a tidal volume because it's too much, because they're going to pop, then I still need the respiratory rate times the tidal volume to still equal 10 liters, right? So I have to speed up their respiratory rate to still achieve the 10. So that's the first part, right? I don't want to pop their lung because their compliance is poor. If their pH is whatever this number could be, you know, maybe it's 730, so they're acidotic, but they're not, you know, 6.9 or 7.1, but they're not perfect, and that's okay. But we know that 10 liters or 12 liters, hey, it could be even 16 liters, is keeping them 730. So if that is based upon a tidal volume of 500, and whatever, you do the math, I can't do it right now, but 500 times whatever to equal 16 liters over here per minute to keep their pH a certain number, then I'm going to say, okay, hey, with the respiratory therapist, of course, their compliance is poor, their air pressures are high, so we need to pull back on this so we don't injure their lung. So we're going to have to increase their respiratory rate to achieve 16 liters still. So this is why if you say ARSNet protocol, lung protective strategy, low tidal volume, fast rate. That's why, because you have to achieve the same minute ventilation. That's the first part. Then what is their oxygenation? So there's sort of like two pieces to that. If you look at the paperwork that the RTs have, oftentimes it's in their top drawer of their carts. If not, you can always ask one of them, just say, hey, can you pull me out one of those papers when you have a minute to find it? Or maybe you already have somebody on ARDSNet. Sometimes they'll tape it to like the Draeger, and so they can refer to it. And what they'll do is it's actually, I'm not saying they don't use their minds, because they absolutely do. It's just one of those kind of protocols where they say, okay, the doc's hypoxic, the docs say, what do you want to do to fix this oxygenation? And what is their compliance? And what are their hemodynamics doing? So do I want to start with what they call the high PEEP strategy or the low PEEP strategy? And so based on their PaO2 and what amount of oxygen that they are on right now, then they're going to decide their PEEP strategy, so they get to pick, and then the RTs will look at it. So then it just comes down to, okay, I'm on 80%, and the docs want the high PEEP strategy, so that's 18 of PEEP. So what is the 18 of PEEP doing? 18 of PEEP is a giant volume of air, maybe, depending on compliance, but a volume of air that's constantly trapped in their lung, never allowed to go anywhere, okay? And that's trying to promote recruitment in their lung, which is going to improve their oxygenation. But that comes at a cost in the hemodynamic world, right? So trying to maximize oxygenation through bigger PEEP and lower tidal volumes and fast rates. Now, what will happen is as they make adjustments, and also just keep in mind, they're not normal patients anymore. So the parameters on which that they do a treatment or not do a treatment are going to be different than the average person, right? So they're going to accept PaO2s, excuse me, of 55 or better. I think it's 55, not 50. Might be 50, but I think it's 55. So, we're not worried about 80, 70, or even 60. It's 55, and they won't even bother with doing anything as long as it's above that. They might even make an adjustment. The other thing is that we are allowed to let their sats go to 88. We're gonna allow for some hypoxia to occur, but it's not bad. 88, not big deal. A lot of COPDers are probably 88, sometimes even less. And they're walking around at Walmart. So the things that we're allowed to let slip a little bit, if you will, but it's okay. So when they get their blood gases and it says, okay, this SAT is this PaO2 is this, then these are the two numbers I'm at. So my FiO2 is here, my PEEP is here. Then if this, then that. So if my PaO2 is above 55 and I'm on 80 and 18, then the next move would be to drop the 80 to 70. It's not dealer's choice. It's not the RT going, well, I think I'd rather do that. No, it's literally spelled out for them. It says if this, then that. So that's what it comes down to, is if this, then that. Now, that doesn't mean that we don't use our heads and say, okay, there's something very bad happening. Maybe hemodynamically, this patient's really falling apart because of this high PEEP. So that's a conversation then to have with the physicians. This isn't, maybe the protocol is black and white, but the world is not. Reality is not black and white, right? Sometimes we do have to actually use our heads and say, hey, you wanted to start with 18. When I got past 16, they literally are dead. So let's maybe start at 16, and maybe we'll bump up our FiO2 and then go from there. Let's augment this a little bit. But the idea behind this whole protocol is that it's very much spelled out for them. If this, then that. So you see the grid, you'll see high PEEP strategy, and you'll see 2 rows. You'll see low PEEP strategy, 2 rows, and it'll have FiO2 over the PEEP. And literally, as they get this gas, if these are your numbers, then and these are where you're at for your FiO2 and PEEP, then the next move is this, right? And one of the big things is we want to try to move people out of the high oxygen levels, ideally below 70, because we run into what we call toxic levels of oxygen. And yeah, I guess that's the best way I can explain it. I mean, I can go in depth about different aspects of these things, but I hope that's what you're kind of looking for, is how do they make these moves. So we've identified what the aspects of the event are trying to achieve, and why ARDSNet is a lower volume and a faster rate. But when it comes to when the RT makes this move, it's based upon the protocol, which tells them we're allowed to have PaO2s down to 55, so as long as they're above it. And if where you're at for these 2 numbers, and I keep saying this because I visualize everything, so I'm seeing the paper and it's like FiO2 and then the PEEP. So based upon these numbers, this would be the thing that you change next, as long as they're obviously getting better. And if they get worse, the same is true. It will say go up. But then again, if there's things that are falling apart, like, maybe you're maxed out on 2 of your pressors, and if they go up on your PEEP, you're on your 3rd and they don't want that, then maybe they'll say, let's do something a little different, So, does that help, Ashley, or is there a little bit more that you're looking for?
No, that was really helpful. Thank you so much.
Yeah. So, I mean, there's so many fascinating things just about the vent. I get excited about it. I don't know, the vent, when you first off, I don't think in nursing school I ever learned anything about a vent. I'm not at all that I can remember. I think we talked about PEEP, but I'm not even sure I understood what that is. Everybody comes out of school going, positive end expiratory pressure. Let me ask the group here. Again, you don't have to turn your camera on, I would love to see some of you though. But if you don't want to turn your camera on, that's fine. But and I do this in my vent class, but I like to just demonstrate things that sometimes we have concepts of, like a theory in your head, but maybe visually you don't understand it. So I always use this one. Does everybody have PEEP? So those who have heard this spiel before, of course you're going to answer it correctly. But those maybe that haven't, do you have PEEP? We put people on PEEP, but do you have it? Like right now, next to your cuddly animals, do you have it? Do they have it? Anybody that doesn't already know the spiel? Okay, the answer is no. I'm just lying. Actually, it's yes. You do. You do. So what I'm going to have you do, again, you don't have to show me this, but if you can just listen to my voice, I just want you to sit there wherever you are, and I want you to breathe normally in and out. Of course, now that I say that, you won't, but I just want you to breathe in and out like you normally would. And then when you get to that point where you're done your breathing out, your exhalation, and then you want to breathe in, don't. Just stop there, okay? And when you stop there, then breathe out more. You'll notice there's something else still in there, right? So we don't fully exhale. So there's your PEEP. That's your intrinsic PEEP. And so that intrinsic PEEP is roughly around 3, right? So this is where, like, when we wean people down to the infamous 5, it's really just to kind of give you something relative close to intrinsic PEEP. Just kind of keep you stented open, because PEEP is there for what? To prevent atelectasis, right? Prevent it or help fix it. But it's that volume of air. So if those that are kind of maybe shaking their heads about the PEEP and why do I keep bringing up hemodynamics, like, hey, you're talking about a ventilator, which is your lung system, right? That respiratory system. So why do you keep talking about the whole heart thing over here? Like, I don't get that. I don't understand that. That's a system, and they're definitely separated, right? No, they're not. They're not separate. They all work. They're all interrelated, and to fix one thing might be to screw up something else, and that's when we think about what is more beneficial now. Someone who might need a third pressor versus having a SATA 40. So, yeah, maybe they'll lose a leg because it's more ischemic, but hey, their brain's going to be okay because they actually got their SATA. It's not perfect, right? Medicine is not going to ever be perfect, at least not anytime soon that I'm aware of. So we kind of think about what is the biggest thing that we need to fix now, their biggest problem, and think about benefits and risks, and are we willing to sacrifice one thing for another? So when it comes to PEEP, do you guys want me to talk about the PEEP and the hemodynamic aspect? So with PEEP, right, everybody, we all are sitting here not on vents that I'm aware of, and you are breathing with a negative inspiratory force. You're dropping your diaphragm down, and you sort of make this vacuum effect, this room, right? So in here, you're kind of allowing for some room to form. And so as you drag air in, which is your tidal volume, your breath, the pressure in there, it goes up maybe a little bit if you take a real big breath, but otherwise it kind of stays about the same, a little bit increased, right? But when you're not taking a breath in, and I force air into your lung, i.e. positive pressure on the ventilator when you're intubated, you're not moving out of the way. You're not feng shuiing the organs over here. And so you put air into that space, and just like we talked about, you now have lungs that have a lining, right? And they're making resistance, right? They're pushing back on that air. So the pressure goes up naturally. And if you have that nice, compliant, stretchy lung, that won't have a huge increase in pressure, hopefully, right? So we're sitting here and we have pressures that are along around like the teens, maybe low 20s, but usually like the teens. And then you get tubed for just a knee surgery, it's elective. You should still be in the teens, maybe low 20s, right? But we get patients that, start to get sick. And as they get sicker and sicker and sicker, they might develop other problems. So they might develop pneumonia, they might develop ARDS or whatnot. But when they do, and they start to get poor oxygenation and maybe worsening compliance, we might need to increase their PEEP for the oxygenation, but now we're battling against more their compliance. So when you increase the PEEP to increase their oxygenation because you're trying to recruit the alveoli, you're trapping a bigger and bigger volume of air in their lung, okay? So when you do that, and that's at all time, right? So I always point to the vent. I am not very good with this whiteboard on the computer. I can barely draw with a pen, so it's crap when I try to draw with a mouse. So I got my fancy whiteboard here. Hopefully, see if I can do this right. So, I always look at the vent and you see these graphics, right? Like this. And I'll always point and say, what? You can see that, right? Barely? Okay. Well, I always say, what's the one common line that you see other than 0 down there? Like the one thing. So I always take a piece of paper and basically you chop off all these mountains, which are your breaths, and you've got this one line right here that's always consistent. That's your PEEP. So unless you pull the tube out, that is the lowest thing you can have in your lung, and whatever that is to keep you alive is it. You can't get any lower than that. So if you need a PEEP of 20, you have a chunk of air in there at all time that's going to keep you oxygenating, hopefully improve your oxygenation, but you're not going past that unless they decrease the PEEP or something else happens, right? So that's the always. So if I don't move things out of the way and I give you more and more air to increase your PEEP, that's going to generate more and more intrathoracic pressure. So then I kind of think about, what does that mean to the hemodynamic aspects of things, right? So if anybody's been a part of an ultrasound guided triple lumen or even a peripheral or something like that with PIC, or just your surgeons or medical docs, whatever, you always see with the ultrasound, they always kind of put some lube on there and then they go dunk, dunk, dunk. They're always compressing. And they always see two big circles, right? Hopefully they're big. And you always see one kind of just staring at you what? And the other one's always winking at you hey buddy, come on over here. That's the vein, right? That's the compressible side. So lower pressure system, more compressibility. So we know that what brings the blood back to the heart? The venous system, right? Because the arterial system brings everything to the body, and then the venous system brings everything back to the heart. So that just taking a probe ever so gently and going doink, doink, doink is going to the vein, and they're the ones bringing blood back to the heart. And then I just kind of, if you think about it internally at the lung area, that I have increased volume to hold PEEP, not to mention the tidal volume on top of that, but just the PEEP alone, higher intrathoracic pressure, and that's transmitted through all the planes of tissue, and that's compressing all those little tiny venules and the little, we're not talking about the giant veins. I mean, those are compressible too, but all those little things that start to carry that blood back, right? And we're decreasing that venous return. So when we decrease the venous return, we lose our blood pressure, right? So PEEP can destroy your blood pressure. This is why if you don't understand that and you just think PEEP oxygenation and you don't know what your respiratory therapist is doing, and your patient might be getting sicker from a respiratory angle and their oxygen levels getting worse, but you don't realize that they're about to go change the PEEP from 5 to 12 because that's what the doc wants to do, I would maybe go get a bolus line, because I know that this is about to maybe destroy that blood pressure. Or maybe I'm on pressors, and if I had no concept of this, that all of a sudden they do that, and then, oh my God, my blood pressure's dropping, and I'm thinking, oh my God, my patient's just getting sicker. No, they're not getting sicker. I mean, their lungs are sicker, right? But they're not getting more septic all of a sudden. You're just having to adapt to that intrathoracic pressure. So that's decreasing. It does two things. I always talk about these two together. So it decreases the preload from into your heart, right? So your stroke volume drops. So we know that if your stroke volume drops as a result of poor preload, then your cardiac output drops, which equals a worsening blood pressure, right? So heart rate, stroke volume, cardiac output. So I've already decreased venous return, so poor preload. But then I always use this, like, because we always talk about the lovely CVP, right? Sucks. This number sucks. I hate it. Hate it. So CVP, we all know, central venous pressure. It's like when you come out of school, PEEP, positive end expiratory pressure. Sure, what the hell does that mean though? So your central venous pressure, just like your PEEP, is a pressure, but it's based upon what? So now we're talking about your bloodstream, cardiac. So we were talking about PEEP a second ago. We said that's a volume of air trapped in your lung. So what is CVP? It's a volume of, hopefully not air, blood, right? If it's air, they're dead. But it's blood, right? So we have blood, and I'm just going to put a little asterisk here. We always talk about blood incorrectly. We think blood is a red blood cell, but blood is the umbrella word for everything that's in there, including red blood cells. So we're talking about the water content. You know, red blood cells, plasma, albumin, the electrolytes, drugs, water. Water is like the car for the red blood cell to go somewhere. So when a patient is third spacing or dehydrated, they might have plenty of blood cells. It's not their issue. They just don't have a car to bring them around. So you need to give them the volume, which is the crystalloid, right? So when someone is, first coming in and their CVP is low, if you would like to take it for face value and talk about it from a textbook standpoint, that number is representing a volume. If I have a higher pressure, I know I have more volume in that pipe, right? So if I take a pipe, so I'm going to do my pipe analogies here. Y'all are doing great, by the way. If I take a pipe, which is that, right, and I fill it up completely, the pressure, because the walls are going to push back towards it, right, towards the volume, is going to create a pressure. And if it's adequately filled, I'll have a decent pressure, right? So let's just say, just for shits and giggles, 5, right? But let's say I take that same size pipe, but I only fill it halfway. I don't think the pressure in there is 5 anymore, right? I don't think so. Would you guys agree? It's low pressure, right? Because it's not fully filled. So I can do one of two things. I can either fill it up to raise the pressure, or I can constrict it down and make the tube smaller to then fit the volume, which will then match that same pressure again. That makes sense? Right? Because if I only had half the volume... I don't know that one. Oh my god, my Alexa just heard me. If I make a smaller pipe, I would get the same volume, or the same pressure, but it's based upon a smaller size, right? This is where vasoconstriction plays a part. So I can either fill it up or make the tube smaller and get the pressure. But there's one more thing. Everybody, even the ones that I can't see, sadly, I'd love to see all your beautiful faces. Probably got acne everywhere from all these masks, right? If you were to just take your arm, I love this one too, sorry, but if you just take your arm and you probably don't even notice your arm, right? So pretend your arm is like that vessel, the whole arm, right? So if, again, using imaginary numbers, you're not really noticing it. So probably if you were to say the internal pressure in my arm right now is probably like 2, okay? Don't feel it, don't even notice it. Take your hand, wrap it around, and start squeezing. What do you think the pressure starts to feel like inside? Higher? Of course. Because you're taking that vessel and you're constricting it from the outside. You're pushing on it. So when you push on it, in essence, it's like you're not vasoconstricting, but you're compressing. And when you compress, you raise the internal pressure. So with with PEEP, when you have the higher intrathoracic pressure, you're taking those vessels and you're compressing them. So you're actually raising the internal pressure without doing anything else. So this is why I hate this number, because if someone is not doing well from the respiratory standpoint and you have to really increase their PEEP, you can actually make that number of the CVP dramatically rise. And what it looks like, if you were to take it for face value, it looks like you might even have to diurese the patient, because we know in the ICU, we love the number 8 to 12 as considered normal when you're trying to hydrate somebody if they're septic or whatever, and we're trying to maybe get to a pressor if need be. We want to make sure there's enough volume that is floating around, bringing all of the things that need to be transported around. So if I don't have a lot, I'm ischemic. So I don't want to add a pressor that's just going to compound the ischemia. I really just want to give you some volume to fit the tube and maybe add a little bit of vasoconstriction, and all is well with the world, right? But if I just compress you, that number goes up. So if your CVP was 4 and all I do is raise your PEEP, I might make your 4 look like it's 10. Well, 10 is tanked, right? Come on, we all agreed 10 was tanked. But no, they're dry as hell. It's just the fact that I have this ventilator screwing up what's happening inside my patient's bloodstream, right? It's compressing things. It's actually making my CVP rise. So this is where, like, sometimes residents who are new and they don't understand all of this yet, or even med students, sometimes the attending who's just really not paying attention, you might have to like say, hey, we made this change. They were actually like 6, and all we've done so far is increase their PEEP because their PO2 is trash and we needed to oxygenate them better, blah, 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 blah. And we increased their PEEP, and all of a sudden their CVP is looking like it's 10 or something, or maybe 12 or whatever. They're gonna be like, oh, no, I would start, they got enough volume. I'd be like, no, they don't. Or even worse, like sometimes you'll see them go past the 12. Ooh, past the 12. Jeez, watch out. They'll be like 18 and they'll be like, oh God, we need to diurese them. I say, you do that, you kill their kidneys. They're dead. Come on, no, we're not doing that. They actually need more fluid. I will tell you why, right? So you have to make sure you're looking at everything. So CVP, in my mind, is nothing but a trending number. I don't care if you're healthy or not. I look at it, I kind of make sense of it. Like if someone, say all those things happen, say they were intravascularly dry, I raise their PEEP, right? Now their CVP is 10, but I know they're intravascularly dry. So maybe I get their PEEP up to 18, their CVP up to 18 because I gave them some fluid. And I know that when they're 18, they mentate, they pee. Well, that's not 12. That looks like diuresis territory. No. Now I use it. When they're 18, mentate, pee, if they can do those things. They go down to like 15, they don't mentate, they don't pee. So guess what? Keep them at 18, keep them at 20, keep them at whatever makes sense to the patient, right? We got to look at the patient, not the number. The number might suggest something, but there's so much more to that, right? So here's just like one aspect that vent can screw your patient over, and that's just modifying your PEEP, right? So there's other things that the RTs might do that might change that, right? So bigger tidal volumes, sometimes the mode in which we're trying to ventilate or oxygenate your patient. APRV is notorious for this because you're having such high pressures to sustain oxygenation, improve that. But that's like code for PEEP, like giant PEEP. Like you're talking about 10s and 12s on the ventilator when you're on CMV or AC, who don't know the old lingo, new lingo, same thing. But what you're gonna see is that the PEEP of 12 on your CMV mode, you're gonna see a pressure on your APRV mode. That's basically PEEP. It's a giant version of PEEP. And we start out with like 36. So if I know that you're going from like 8 to 10 to 12, and I might suggest go and get a bolus line, or if your Levafed is there, you might have to go up a little bit if they start to trend up on this PEEP. If I'm going from that mode to APRV, and I know, hey, whomever, like Dave, what are you going to start off at? I'm going to start off probably around like 34. Okay, hold on 1 second before you hit that button. Let me just go get a bolus line. How much Levofed's left in my bag? I just want to make sure I got all my things, right? Now, that being said, everything I've said to you is a theory, right? And it happens, but it doesn't always happen. I've had extremes where patients go from that mode to that mode, their assist control to their APRV, and it's a very dramatic change in number. Nothing happened, right? But I've also had people go from a subtle change and like die, So what it is knowing that the concept, so it's like you're ready for it. I'm ready to know that this problem could occur. So if it does, I'm already a step ahead of the game, right? Instead of like the RT making that change, you don't know any of this. They make that change and you're like, oh my God, call the code, the guy's dying, get me this, get me that. It's like, no, you can avoid all of that. You can just have everything ready. And then it just goes into another conversation. I mean, I could go on all these tangents, right? What fluid do you grab? Is it isotonic? If so, which one? Why? What are the electrolytes? Why don't you do this? Why do you do this? But all these things to think about. But if you want to stop here on this change from one to the other, knowing that there might be a dramatic change in your hemodynamics solely based upon PEEP, then isotonic fluid if you think you need it, if you think they're going to drop. But also know that they're not magically getting better either if their oxygenation's improving and they're dropping their PEEP, and all of a sudden you're like, damn, I haven't had an opportunity all day to wean this Levofed, and holy shit, here it is, now I'm doing it. So, as an example, actually the last 2 shifts I worked, yesterday and the day before, I had the gentleman who's on CVVH who was on actually high PEEP of 12. And the person I'm orienting, we actually explained this just the day before, which was like all the stars were aligning. And this gentleman had like an okay blood pressure. He wasn't on a pressor, but his pressure was like, just okay. MAP just okay. And then his SAT was just riding 99. So, you know what? We don't need a gas to tell me. I mean, if it's 99, unless it was like carbon monoxide, he should probably have an okay PaO2. So he went from 12 to 10. Guess what happened to his blood pressure? Anybody? One person.
It went up.
Oh my God, it went up! Oh, it's brilliant. We had room to do other things. It was amazing. Oh, I love this stuff. So, yeah, no, and it made sense, right? Like pointing this out, it's like you talk about the theory and then boom, slaps you right in the face. There it is. The RT made the change. And furthermore, later that shift, his SAT was still rocking 99. So guess what? There was no carbon monoxide that I was aware happening in that room. So, and he didn't smoke a cigarette. So his SAT was 99, so we thought his PO2 should probably be fine, so we didn't bother getting a gas, and we went from 12 to 10, and I bet you know what happened next. His blood pressure just got that much better. So it makes sense when you put these pieces together. So the vent's like not just a vent, and it's over there, and that's lung. And this is cardiac hanging up in some IV form. And the green machine is just a kidney over here. They're all doing something with each other. It's like, walk like an Egyptian kind of thing. It's all, intertwined and integrated. And, one thing that you do will affect something else. So it's like, what are you willing to sacrifice? So if you can't oxygenate, starting with your basic ABCs, if I don't have enough oxygen in your body, things are going to shut down. Your brain's not going to get fed, right? All these things are going to get neglected, and they're going to starve for their oxygen, and bad things are going to happen. So if I need to increase your your PEEP in order to compensate for that, to overcome all of that, and at that cost is you need to go on a vasoactive for a little while in the form of a pressor, and it's not like tons and tons of it, like jet fuel and 4 of them, then that's okay. It's okay. It is what the patient needs at that time. We know we have things that happen, and it doesn't happen to everybody, but sometimes people, when they're septic and they need their volume, and then they need their their vasoactive, like their levofed, their vasopressin, and then they need higher peeps and stuff, and eventually maybe they need a little bit more of their levofed because they had to increase their peep to increase their oxygenation, and maybe they're starting to have like some toes that look a little funky, like a little bit black. Listen, at the end of the day, if this patient walks out of here with 3 out of their 5 toes, but they're alive, they should be thankful. You know, it sucks. No one wants any of those things to happen, but the reality is those things can happen. Motto I have: there's a pill for every ill, but there's an ill in every pill. No matter what you do, something's gonna happen, right? So what are we willing as the team to sacrifice? What is more important at this time? You know? Oh, they're getting modeled. Well, let's fix the modeling, so let's forget about this thing over here. Like, that might not be okay. To survive, that might not be okay. You know? We want all the things to be perfect, but it won't. How are we doing? Yes, you.
I have a quick question. Not to go back to PEEP again, but could you talk a little bit about PEEP and auto PEEP when it comes to our COPD patients and weaning them off the ventilator? I feel like it comes up in rounds a lot, and I'm able to hear like half of an explanation, but I just would love to hear the whole spiel to better understand COPD.
I'll give you my best. So
Awesome.
Auto PEEP, we just, this is amazing because I just demonstrated that you have PEEP, right? You have PEEP. So that's your PEEP, right? But what is unique about COPDers? Well, one thing we always have the habit of when we learn about COPDers, especially in the ICU, is everybody's like, they're all retainers. No. Please don't think that way. COPD is a progression of a disease, right? You can have the start of COPD and you can have an extreme version of it, like the worsening, very end stage. And what that is that, the infamous smoking, but it could come from other things. It could be factory working and, you're exposed to something that injured your lung. But what's happening is that with injury to the lung, right, your body tries to achieve homeostasis in every way possible. So in this form, if it's injured, it tries to heal. Well, if you cut yourself on the outside, it heals, but it doesn't heal the way it was before, right? It's a scab, and then it's scar. And so internally, when you repetitively injure your lung, especially with like smoking, the common one that we think about, is that there's injury and then there's healing, and injury and healing, and injury and healing. Can you imagine years of just like sitting here and cutting your arm like in the same spot over and over, waiting for it to heal, and then cutting it again, and then I don't even know what that would look like. That would be just, I can't even imagine it. I have a visual, but I don't even know if that's right. But internally, what's happening is that, you have healthy lung, right? And you have these beautiful grape sacs, and, you have your bronchioles, and everything looks perfect. And then as you injure and injure and injure, and things start to scar, the parenchyma starts to change. It's not the same air spaces anymore. And we know that in breathing is a very passive thing, especially to exhale, right? We actively will breathe in, but to exhale, it's like, you don't think about it. I mean, if you're out of breath, maybe because you just ran or something, that's a little different. But you don't really think about it. It just happens. It's passive. But as you reoccurringly injure and injure and injure, the parenchyma starts to change its shape. And as it does, the air spaces aren't the same. Air gets put into those air spaces like with the breath in, but it doesn't get to work its way out the same way. And so as you know that the progression of COPD, as it gets worse and worse and worse, their exhalation phase becomes more of an active process. I don't know if you've ever seen end-stage COPDers. They're like the exact extreme of like obviously the people who are brand new. But if you've ever seen them, I worked in a nursing home before I was a nurse, and these guys are the infamous, they're like cachectic, they're tripoding, they're pursed lip breathing, the whole textbook thing, and they're like, and as anybody without any COPD knows that if you are, let's say the dead of summer when it's disgustingly hot, and it's humid and you take a breath in, it's uncomfortable. You want cold air, right? It's like, give me some air, and it's just like when you're in a burn room or any of the rooms where it's like when you're in your damn Pampers downstairs. It's like, oh my god, I need air, right? These guys, they want a fan on them constantly, and they can't breathe, and they're trying so hard to exhale. Well, why are they trying to exhale? Because the air that went in is not able, with the way the lung is kind of injured now, that parenchyma, they actively have to kind of like think about like squeezing it out, right? So if you have an intrinsic PEEP of 3 and your lungs are nice and healthy and they're air trapping a bunch of air and they physically can't get that out, that's a volume of air trapped in your lung. What is that? PEEP, right? So an excess of this in a COPD is creating a higher level of PEEP, which is this auto PEEP. So sometimes what RTs will do, especially if they're really the patient's really desynchronous with the vent, is they'll try to match what the auto PEEP is. So they have this little, it's not just there on the screen, they have to push a button and kind of analyze their breath to understand. They run like a little diagnostic, and then they'll go and tell the physician or the resident they have an auto PEEP of 10, right? So it's not your 3 anymore, it's their 10. So what they sometimes will do is they will increase the PEEP on the vent to 10 to match it, so that every time they try to breathe down, it's not being triggered to give them more air or trap more air in them, because now the pressures are going to get even greater. So that's one option, but sometimes and all patients are different. So what I've seen over my years is that they do that. Sometimes the patient's great. Sometimes the patient then stacks more air, and it's just like a game of chase where, you know, they have to keep increasing PEEP to match more auto PEEP, and it's just like, you know. So another way around this is why sometimes, this is one way, there's other ways, but one way where you're so used to seeing, I would imagine by now, all your sick patients, when they're on pressors and all these other things, for the most part, they're always on assist control, right? They have all these other problems going on. Their pH is altered. They have processes internally, whether it's lactate or DKA or whatever. And they're, you know, we're trying to take them out of the picture. We're sedating them and we're putting them on CMV or assist control, right? You might have that same patient with all of those problems who's a COPD, who is having auto PEEP. So what they will do is they will put them on CPAP, which seems weird because they're so sick. It allows them to have as much time to exhale as they would like. Because if they are having a problem with a metabolic process and we're trying to give breaths too fast, they never really have their opportunity to really get their air out, right? Because if they were like not having this problem, they might take, let's say, 2 seconds to exhale, where maybe we just need 1 because we're healthy, and we're only giving them 1 on the vent because we're putting the next breath in. So they're just not able to ever fully exhale enough air, and all that's trapped in there, creating a higher PEEP. Does that make sense? And if you think about it, that higher PEEP, their auto PEEP, that higher PEEP, is the same thing as if you had gone to the vent, turned up the PEEP, which means higher intrathoracic pressure, which means hemodynamic issues, right? Especially if you're trying to match it and then go even above it if need be. So it's to treat it as not like black and white either, but there are these options for patients. This is why sometimes you'll walk into a patient, they have a bad diagnosis, like really bad COPD, end stage or something, they're septic, they're, you know, we're giving them fluid and they're on pressors and stuff, and they're on CPAP, and you're like, what? What? Did someone forget to hit the AC button and like confirm? You know, but in fact, it's maybe allowing them to exhale longer to get rid of more CO2, which means their pH will be better. Maybe sometimes we don't do the best job, you know? Sometimes they need to do it. We can only do so much. Sometimes we screw it up. It's trial and error. Cheers. Does that shine a little light on there? Okay. Anybody have anything? I see some newcomers. We've been talking about PEEP. Ashley brought up a question about ARDS and the protocol and why are RTs weaning in such a specific way. So we talked about what is PEEP, compliance. We touched on some of the hemodynamics of what the PEEP does to the patient. Yeah. That CVP number, oh God, such a trashy number. Such a trashy number. So a bunch of other things that make that number go up that aren't like in a good way where I'll be like, yay, you know. So what else? Does this, can you, is there a scenario or a patient that you recently had where now you can apply what maybe I just said and go back and think about it and be like, okay, now that makes sense. Now I know why that problem with the vent or maybe their hemodynamic change makes more sense now because now I have a better understanding about what was actually happening to them internally. Are anybody able to do that? Do you want to share a story about one of them? Like give an example of what maybe you just ran into? No. Are you running into the? Do you work in two, right, Kala? And do you go to COVID?
Yeah, I do sometimes.
Okay. So has this been? You said you've heard this several times in rounds. Is there an example that maybe you want to share about a patient?
I don't have a recent specific one.
Okay.
I just think oftentimes with our COPD patients, when they're right at the cusp of intubation, we'll say, oh, remember they have COPD, we're going to intubate them, we're never going to extubate them, or, you know, we'll be weaning them, trying to get them off the vent for weeks on end,
Yeah.
Or maybe not weeks, days and days on end. And I think often people aren't talking about this auto PEEP phenomenon, and we aren't necessarily incorporating it, but I don't have a specific patient in mind.
Okay. Yeah. Well, I mean, I guess at this point on, you know, if you start to run into another patient like that, you know, think about this conversation. It might make more sense. And again, it's not a number that you can just see. RTs run diagnostic, and you know, most of the RTs are very approachable. You know, some are a little moodier than others, just like nurses, right? But you know, you can walk up to one of them. Some of them love to. Jim Roy, he's great. He loves to just educate if you ask him questions, and he'd be happy to talk more in depth about it. Maybe even give more pointers than I just did. Show you what they do on the vent so you have an understanding, and you know, so definitely ask. Don't be afraid to ask any of those questions to anybody. Like, I know people sometimes get nervous, afraid, maybe feel embarrassed or something like that, but you gotta ask what you don't know. I mean, that's why you're sitting here now, is to just ask questions that you don't know. I have a bazillion questions I have no idea about. So, I mean, there was questions again from last session that I couldn't answer. I didn't feel like I could answer very well. So, it makes me want to know more. So if you have that question, ask. And if you have more insight and you come again, you could always come back and be like, hey, everything you said was wrong, and also there's this. So I learn constantly. I've adapted over the years. Like stuff I thought I knew, I was like, ooh, I don't think I was actually teaching that right. I think this is actually better. I think this is really what's happening. So, you know, but you gotta keep fumbling and keep on going. Don't give up, you know. But ask, and you've been around, I think, long enough where you're seeing the same docs for the most part. I mean, residents come and go, but a lot of obviously the attendings, and there's a lot of PAs and NPs that stay around. So we build this family, right? And so I feel like people start to get very comfortable and they learn your personalities, and then they're very welcoming to asking questions. And I ask the pharmacists all the time questions about meds. Sometimes I'm like, I think I know about this med, tell me if I'm wrong. So just use your resources. But if you have something like that, ask the RT to maybe demonstrate that diagnostic on the vent, and that way you have maybe a little bit more understanding, and maybe it sticks better or whatnot. So. What else? What else we got? Was there any questions that anybody had coming like into it, or do you have it doesn't have to be anything we talked about, but do you have like an experience that maybe you want to talk about, that maybe you just haven't worked yourself through it, like things happen and I just don't know why, and you want to talk about it? It can be about anything.
I have a question. It's not necessarily related to like a specific thing we've talked about, but what do you like? What's your opinion on like? Because I'm in nursing school and I graduate in May. What do you like? What's your experience with people coming in like as new grads starting in the ICU as an RN?
New grads are like my forte, is my specialty. I love them because they're new, and I love to mold them. I love to see all the different personalities. So I was a new grad, so right out the gate, everybody that's ever been a new grad, I 100% can relate to, because I went from nursing school right into the ICU. I know no other nursing, and it's scary as hell. So if you're someone who already works in the unit, who is interested to work in the unit as a nurse, the things that I suggest are, one, being eager to help, eager to learn, ask questions, not be on your phones all the time, like always like showing initiative and curiosity, and those are like really, really big pieces that I think of, because I've seen some of the nurses that were CNAs, and I'm like, they're gonna be great. I mean, they never sat down. They're always like helpful. They're always asking a ton of questions, and you could just tell, like, as a nurse, they have that drive. They have that motivation. The people that are like and just kind of sit there. As a candidate, I'd be like, no thanks. Like, you weren't that helpful then, and you're not probably going to be that helpful now. Maybe you have the drive and you see what we do, but I don't think you had it when you were a CNA. Why do I think you're going to have it while you're a nurse? So that's just one thing I personally think about. I'm not the one that's interviewing, but I just look at that. I've had people, want to interview, and people come up to me and I'm like, no. And other people are like, oh yes, like absolutely. So that's one thing, is just show the curiosity, ask the questions, want to be there. That's a huge thing.
Okay. Yeah, I was just because it's something I really like am very interested in working there, like as an RN. Yeah. But I just wasn't sure how likely, like the likelihood of getting hired directly into the ICU.
That's a huge variable that has nothing to do with any of this. This is one, when you get out of school, do we even have a position? How many positions do we have? How many candidates? How many new grads are we taking on? Where is the need? What is your interest? Some people are like, I don't want anything to do with neuro. So maybe the only position's neuro, and you're like, forget it. Sometimes, now, I will say, sometimes people show all of those things I talked about, right? But maybe you watch them and they're like, they don't quite have it yet. So those are the people that have a drive, have a motivation, but what you might see is that they would maybe benefit from working like a year on a med surg, just to really slowly adapt to what is being a nurse, Because when you're a new grad in the ICU, it's 6 months of trying to figure out how to, one, just be a nurse, and then two, all of this advanced material. It's a lot. I mean, it's just a lot. And people who are off their orientation who have been here for 6, you think 6 months, if I said, hey, Christmas is in 6 months, you might think that's forever, right? You go and start being an orientee in the unit and 6 months feels like it was a week. And you're like, wait, I'm done now? So I'm not really sure I'm comfortable in any of this. I mean, there's so many things that are happening, you know, and like I said, you're learning to be a nurse and you're learning all of these intricate things about what is ICU nursing, you know? So I feel like when you're a nurse or when you're in nursing school, you learn like 1% of what you are to be a nurse. The 99% after that is on the job. So going back, there have been people that I think would do very well in the ICU, but I could tell maybe they would benefit from like doing a bit of a slower pace. And what I mean by that is go be a med surg nurse so you can really adapt to being a nurse, and then come, because I feel like that might be just such a better flow for that person. It doesn't mean you're shittier nurse and you're dumb. It just means that fits you. That just is what's going to make you the most successful. So the whole like likelihood of getting hired, that is, I couldn't even put my finger on that, you know.
All right, thank you.
Yeah, no worries. Welcome to my dining room. Anybody have any other things or experiences you want to share? You know, there's things that sometimes, especially when you're on orientation and even sometimes well after orientation, but you might have had a patient where you were so busy and it was such a task-oriented day and you really don't know why you were doing the things you did. So I often tell people to like write things down and maybe come back, and then we can like break it down and be like, okay, remember when this happened? That's why we did that. Does that not make sense? So I don't know if anybody wants to talk about a scenario like that. I'll let people kind of ponder for a second. I also mentioned for those who did come to the last Q&A, if throughout the weeks, if there was something that came up, to maybe like jot it down so that if you wanted to talk about it this time, we could. So I don't know if anybody's done that or remembered anything. But questions, and it could be anything. I mean, really anything. I'll give you my best. That's all I can promise is my best. Some of the names only actually, no, Lindsay, okay, no, I know everybody, forget it. For a minute there, I thought I didn't know somebody. It threw me off. When people like leave and then come back in, everybody starts to move around, and I'm not sure I'm looking at the same people anymore. I see Jess is in here, and I know a few weeks ago we were talking about people who are precepting and trying to figure out what might be a good way to help in people who are doing the precepting role but maybe feel really either uncomfortable, not really know what they're doing, don't know what maybe to teach. So I know that there's some stuff coming where I think Amy and Alana are going to put some more, I think, like educational aspects first. And then I was kind of offer something more like this, like a Q&A, but really geared towards like precepting, like, hey, if you had an A-line, what would you talk about? What would you describe? What do you think is important? What should I actually know about it? You know, so, but anybody has, that's actually precepting, you know, those, you can ask questions about stuff like that. Anything. If we haven't anything to think about, how about I just kind of go back to Ashley's question about the ARDS, and I was just teaching this concept the other day, and it's so funny how sometimes you talk about a theory and then literally like the next day you're standing in front of a patient that's actually having the theory you just explained. And so a couple days ago I was doing like a one-on-one teaching, and the last 2 shifts in my unit, not my patient specifically, but we were talking about the concept of good lung, bad lung. And you know, the I don't know if people are familiar with that, have heard it, don't really quite understand it. So going back to you know, like a idea behind what you were asking, Ashley, is, you know, you have an issue with ARDS about, you know, an issue with ventilation and perfusion. So we call this V and Q, so ventilation and perfusion's Q, and we have these mismatches. So, you know, is the problem I have enough blood but my ventilation's poor, or is it I have, you know, a problem with the perfusion but the ventilation's fine, or do I have a problem with both? You know, so in these instances when ventilation's your problem but perfusion's not, you try to maximize that. And so one of the things I was teaching is the concept of good lung, bad lung. So as a coordinator, I see this a lot when people, you know, get admitted to a floor, or maybe they've been on a floor for a couple days, and all of a sudden, you know, I fly up there and their patient's like laying in bed and they have a non-rebreather on, and they're like, my patient, their sats dropped, and I'd be like, okay, so why are they here? You know, tell me what's going on. You know, blood pressure, okay, I'm looking at the monitor. I'm like listening to this, I'm multitasking, looking there, listening here, assessing with my, you know, all these things. And I'll hear them, oh, they came in for a, you know, left-sided pneumonia or a left-sided effusion, and they're like way up on their left side, and I'm like, hold on, okay, keep talking. So I'm like, hey, go over there and just help me turn them real quick. And they're like, okay, so this guy's chewing my ear, telling me what's going on. I'm looking at that. I have somebody on the other side, and we're boosting them up because they're also at the foot of the bed, and we flip them over to the right, and all of a sudden their sats are 100, or they're vastly improved, they're on a nasal cannula, and I'm like, the patient does not need to come to SKU, so pump the brakes, and we're going to talk about why what I just did worked. Why did this change something? I love the cat. So, so the concept of good lung, bad lung, right? So we have an issue with atelectasis, or as I say, schmutz in the way, when you have mucus from the pneumonia, it's like spackle inside there. There's just something preventing oxygen getting through that membrane into the capillary beds. Or even something like pulmonary edema, where there's a layer of water that's kind of inhibiting that ventilation, right? But I need to like move that stuff out of the way. So we already talked about how PEEP is that method to try to, you know, increase recruitment to the alveoli sacs that are not recruited, not working, not functioning, and open them up. Now, PEEP isn't really going to help with mucus. It's just going to push it even in further. So that's not going to be beneficial in the mucus world. But it's beautiful when you have water. So people go in flash pulmonary edema on the floor, or, you know, they start to fill up, and the first thing they want to do is, you know, they want to do rescue BiPAP, right? Well, why does BiPAP work? Well, the idea behind the pressure and forcing, like PEEP is kind of pushing, and it can displace water through the tissue, and there you get your surface area back for diffusion. So gas exchange can occur, oxygen in and CO2 out, right? So when we have the concept of good lung and bad lung, and maybe I'm not able to move the mucus out, and I don't have a method to get the water out of the way for a moment, I just have something like right in front of me, non-breather, this is all I got. Well, as a bedside nurse, you have a non-pharmacological ventilatory method of helping to fix that, possibly. Pretty good chance too. And that is to position the patient on the area that is not affected or not as affected. Maybe they have bilateral pneumonia, but maybe their left lung is completely whited out. And the right one is kind of gross, but we got some good aeration in there somewhere, right? So what I can do is I can maximize the perfusion to the areas of the lung that are actually having an okay gas exchange, right? So if anybody has ever stood on their head, where does all the blood go? On your head. Your head turns red, right? So why? How is this happening? This kind of thing, Isaac Newton, right? Like apple fell, called gravity. Gravity helps, right? Pull blood down. So if I don't have a way to move stuff out of the way, but I have some functioning alveoli that can have a good gas exchange, why not put all of the good blood there so that it can pick up oxygen? So when you have somebody with a bad left lung and an okay right lung, I want to flip them on their right side because I'm going to have gravity help facilitate blood moving to the right side, and therefore it can pick up more oxygen to oxygenate the body, right? So in these instances where I run up to a code white on a floor, I might see literally this concept happening in front of me. They're telling me the patient has pneumonia and their left lung is whited out, or they have an effusion on that left side, and the patient's literally on their left side. I'm like, get them off the left side. These are those times where you have the patients that are that brittle on the ventilator, and you try turning them to a side, and you notice every time I put them on that side, their sats just plummet. So sometimes that you do back and forth with the nurse is like, all right, I've been doing supine right, supine right, supine right, right? Or correct? Because I don't want to put them on their left side because it's just not working right now. And it doesn't mean you never do it. It just means like maybe right now. Maybe next, tomorrow I'll test it a little bit. Maybe we'll do like a little gentle tip in that direction and see how they do. Oh no, crap. Okay, supine right. Or hey, it kind of worked out. It wasn't, the other sats drifted a little bit, maybe 94, now they're 92. Okay, leave them on their left side. That's fine. But if it's like obviously dramatic and it's not okay, then that's not what we do. You want to get them off that side. So why did I bring this up? Because we just proned a 500-pound patient for this reason, right? Just like in COVID world. Now, I can't speak a lot to COVID. I've never worked in COVID. People don't want me to do it. I thank you. But I don't, so I can't speak a lot. But the concept is the same thing, right? So whether you have COVID, the flu, ARDS, bad pneumonia, whatever, good lung, bad lung is a universal concept. So if my patient is doing poorly from whatever reason, and we talked about increasing PEEP for oxygenation purposes, and it's still not working, and we're getting to those toxic levels of oxygen, i.e. 100% or greater than 70, I don't want to keep a patient there. It's just not working, and maybe we have nowhere to go, right? Well, let's think about positioning. Where are all of our patients pretty much the moment they get admitted? What position? On their back, right? Sure, they're on their left, but they're supine left. They're supine right. They're supine. They're just supine. They're always with their backs to the floor in some capacity, right? So the areas that are most likely affected from these processes are going to be posterior. So when we talk about left and right and like I'll tip you this way because that side's not as good, I want to bring more blood to that better side. Well, in these instances, if I run out of room, don't think left and right, think front and back, a different plane to think about. So proning is to allow for postural drainage, of course, if that's a thing, if we need to do it. But really it's to maximize blood flow to the area of the lung that's better. And in this situation, it's the anterior surface. So now your gravity is helping to facilitate blood towards the front of the body. So hopefully more oxygen is being picked up and obviously delivered. And at the same time, whatever maneuvers you're doing on the ventilator are trying to still assist on trying to recruit, at this point, postural drainage. If a lot of crap is on the top of, on the back of their lung, which is now on the top, and gravity's gonna let it, think of stuff just dripping off the ceiling, right? And now you might have mobilization of secretions. Now maybe you're able to suction a lot of stuff out. Because you also have to think, PEEP kind of stuffs that stuff down, right? It's really good about displacing water down and out, but mucus also goes down and out. This is why if you have somebody who has really bad imaging, but they don't sound terrible. I mean, they don't sound good. Like, they don't sound coarse, but they just sound diminished. They don't sound clear. All right, that's not what I'm saying. They just don't sound the way you think they should. Well, it's because the PEEP is stuffing that stuff down. If you were to pop the PEEP off or pop their ET part from the vent circuit, all of a sudden the amount of pressure that was to be released, you might see them erupt like a geyser and all this sputum comes flying out. So you have to, postural drainage is great as far as this proning goes. But so you might get mobilization of secretions by moving them, but you're also maximizing blood flow to those surfaces. So now their hypoxemia is improving, therefore their hypoxia is improving, and you leave them there for an absurd amount of time, like 16 hours, and then you flip them back over and fingers crossed that, one, they don't die, and two, that everything is an improvement, and that maybe by being back in their original position that you might expect them to go back up a little bit on their settings, but not to the degree that they once were. So this is a vast improvement from where they once were, and hopefully to decrease the amount of pressures that they need and also the amount of oxygen that's required. Because we talk about oxygen, it's very simple. We always say, oh, their FiO2 is 100%. Oh, their FiO2 is 35%. Let's talk about the oxygen. What the hell is the other percent? If this is 35 and we know everything adds up to 100, what's the other stuff? Like we all say, we breathe. What's atmospheric oxygen? Allie, what is atmospheric oxygen? You're in nursing school. Or you?
Which alley?
Oh yeah, sorry. Either one. How about this? It's the drinking age.
21.
21.
Hey, right? So 21, right? You see, now you won't forget that. It's 21% drinking. So it's 21. In the volume of air you were just breathing, 21% of the gas was oxygen. So no one ever thinks of the other stuff. And that other stuff is actually very important. Biggest one being your nitrogen that's also in the atmosphere. When you breathe that in, nitrogen is a vasodilator. So if I get to the point where I am not having really any other gas but oxygen, that nitrogen is really not in my body much at all, or eventually going away. And so the term we use is like nitrogen washout, because I only have 100% oxygen. Now there's no other gas, or 90%. So the mixture of carbon dioxide and radon, hopefully not radon, but nitrogen, those other gases that are in the atmosphere, there's not much of that anymore. So the nitrogen, especially, that's responsible for some vasodilatation, is no longer there. So on a microvascular level, especially in the lung, this is where you're going to see it, because it's happening everywhere. Don't forget, all this stuff is happening everywhere. But in the lung, those little tiny vessels are getting so small and not dilating that there's causing a little infarcts, ischemic infarcts, that just damage your lung, leading to ARDS. So I'll tell you a story. When neuro was not by itself, we took care of everything. So one of my favorite populations was really sick neuro patients. And I remember this young kid, he was in a car accident. He had a couple broken whatevers. Not really too banged up, but he had a really bad TBI, really bad injury. And we had to, we had the Lycox, which is this like sat probe, but like for your brain. So it's the same little like red light, like ET for your finger, but it's in your brain. And they put that in something called the penumbra. So when you have injury to your brain, that primary spot, whatever's damaged, is kind of like damaged, is a done deal. So as our job is to protect the rest of the brain, and the area next to die is the secondary injury, which we try to do everything in our power to prevent. and that's the penumbra. So usually this Lycox, the sat probe, is kind of stuck in that area. And we're fingers crossed trying to make sure we oxygenate that area, because if we know that's oxygenating, the good stuff is going to be fine. So if this is okay, the rest of it's definitely okay. So if I can oxygenate that kind of next in line to die area, then we're doing a great job. So I do everything I can. Well, if that number goes down, I try to fix it every way possible. Sometimes they don't have a blood issue. They're not here for hemorrhagic, shock. But I might give them a lot of blood only to drive up, their hemoglobin, which is the carrier, right? And I might just try to like I don't say oversaturate, but really drive up. We usually use 10 and 30. We know around here we don't do shit until it's 7 and 21, right? But these guys are a little special. So we were driving these guys up to like 10 and 30, right? And it's like, okay, they're 11 and 35. I don't know. Their oxygen, which is called PbO2, parenchymal blood oxygenation. That thing was lower than 20, and for whatever reason, that's the number everybody chose, and that's the number we want. We want their PbO2, which is the oxygen of that brain, that spot, to be above 20. And guess what? The units of blood didn't take care of it. So positioning. What are all these other things we can do? Well, what's another way I can increase your oxygen? Well, we talk about FiO2, right? PEEP, right? Ooh, PEEP, not so good here though. I just told you all that stuff about PEEP, great, right? Now it sucks here. Why? Increased intrathoracic pressure decreases the amount of blood that's allowed to leave the head. So if my ICPs are high, this is going to be a struggle. So I don't necessarily want to use PEEP in this instance to fix a PbO2. Your PaO2, fine, right? Are you guys following? Your PaO2 is totally fine this whole time. It's this one stupid number. It's like looking at a damn CVP and just doing everything to fix that number, but everything else around is fine, right? This no good, no bueno, right? So PaO2 fine. I don't really want to go up on the P because that's going to make this worse because the ICP trouble, blah, blah, blah. I do all these things, positioning, mannitol, you name it, and I just... FiO2, right? More FiO2. So PbO2 creeps up a little bit more. I got my patient to 100%. Their PbO2 was just 19. That was it. That's all we could do. So for a couple of days, he was on 100%. He went into ARDS. He did not come here for a lung injury, but we gave him one. Why? No nitrogen. So I just want to point out, we always talk about FiO2 as the oxygen, which is obviously very important, right? It's necessary for life. But, just to wrap your head around what's the other missing piece? Like, that's how my brain works. It's like, okay, we talk about this, but if that's 21, then what's the other 79, 80, 20, 80, what's 79%? What's the other stuff? Methane, because I just farted in the room, but, nervous, I ate beans, I don't know. Hopefully no radon, but maybe a little bit. But does that make sense? So hence why I say 70% or less. So, I say I don't know who, someone obviously with a way bigger brain than mine decided that safely can we administer 70% consistently without, killing somebody's lungs, because they have at least enough of those other gases to do what they're supposed to do in the human body, not to further compound injury. Yeah? So, good lung, bad lung. If I can put you in a position that pushes or pulls blood to pick up more oxygen and improve your PaO2, ultimately your SAT, your SpO2, right? Or your SaO2, then I won't need as much oxygen delivery, right? Or hopefully. And maybe I don't need as much PEEP. Now, we're not talking about the neuro patient I was describing before, but let's say you were on 20 of PEEP. Maybe I need 15 now. Maybe I was on 120 and now I'm on 80 or 70 and 15, you know? So way less pressure, way less oxygen, and his numbers look compatible with life. Yes. So in COVID, again, never having worked there, I know that you guys will prone patients, and it's to help with this concept, right? You know, secretion wise, I don't know what things are looking like down there. They have probably all kinds of problems going on. So, you know, maybe they're drooling for this and that's happening over there. But, you know, you might have postural drainage occurring. You're maximizing lung surface area for better oxygenation and hopefully being able to wean down on some of your settings. And then again, fingers crossed, you flip them back over and they sustain. Or maybe just go back up a little bit, but not where they were. Hi, Judy. Are you wanting to say something? Oh. I can't hear you. You sound like a robot. I don't know if you have to log in, log out.
I just texted her to tell her that she wasn't on mute anymore.
Oh, yeah.
I think
It'd be
she's
helpful us to
driving.
talk about acute GI bleeds and mass transfusion. Yeah, we could talk about anything. Am I able? Oh, I can put her. I didn't realize she gave me host. I didn't realize I had that power. I muted her. I don't mean to do that. I wasn't being mean. I was, you know, it was love. So a question about GI bleeding. Well, fun fact, if everybody goes like this, okay, this is exactly the same thing as the other end down there. It's one long tube, so your lips look just like your butthole, okay? So fun fact there. Think about it. It's one tube, one end to the other, right? Oh, no worries, Kala. So GI bleeding, various reasons, right? Ulcer disease, big one. GERD. I think in Maine everybody has GERD. I don't know, just GERD. I'll have GERD. You know, you could have swallowed something could cause a GI bleed. Could be medications. Could be H. pylori. I don't know. Various things. And then we have upper and lower. So, you know, when you think about upper, kind of the classic things that you want to think about are the coffee ground emesis, because you're digesting the blood and then it gets into that little crumbly kind of appearance that looks like coffee grinds. And so if they're throwing up, you'll see it. If you have a OG or an NG and you decompress them, you're able to see that. It's good to decompress them because as anything builds up, hopefully at best they'll just dry heave and nothing will come up, because we worry about what if they were to throw up. Aspiration, right? Don't want anybody to aspirate, but that's always that potential. So decompressing them hopefully will lead to less irritability, and then maybe less vomiting or dry heaving. And maybe if they do feel like they vomit, it's just a dry heave, nothing comes up, and we minimize that risk of aspiration. So just because someone's GI bleeding does not mean you shove a tube down there. And in fact, I would think don't do that. And the reason why is because what if the GI bleed was like a varice from, like, you know, portal hypertension, and this was an alcoholic who had really bad cirrhosis, and that was that. You know, I don't want to shove a tube. So knowing your patient is important so that I don't put the wrong thing there. Because what if you put a hole through the varice? You know, might have a whole new problem. That's like going to the OR kind of thing. So we talk about the upper stuff being more of that coffee grind looking thing, maybe frank blood if it's really high here and not being digested in the stomach. When we think down below, obviously it would be frank blood down there, right? Sometimes if you really look at your patient and you start to see this, and maybe this is not why they're here, and then you start seeing some frank blood, make sure it's not a hemorrhoid. Just pointing that one out, because sometimes that is, you look at somebody, you're like, oh my God, I think they have a bleed now. I'm gonna have to call the doctor. And then you look and you're like, oh, I think that's just like a hemorrhoid. And some, witch hazel, Tux pads, some Preparation H. By the way, Preparation H, great for wrinkles. Does anybody know why? Why it also works down there? So it's a beauty tip as well as an educational tip, okay? So Preparation H for hemorrhoids, you wipe it down there, it helps, but you can use it on the wrinkles and it makes them go away temporarily. Why?
Is it like an astringent or something? I'm guessing.
No. Anybody else? Going once? Going twice? If anybody's familiar with the drug phenylephrine or neosynephrine or neo, however, which way you want to call it, so that's the active ingredient, which is going to cause vasoconstriction. Yep. So it's going to cause vasoconstriction. So it helps decrease the vessel here which is the hemorrhoid. But because it helps decrease the vessels here, it tightens the skin. And so if you're going to go out for the night, now be careful if you have hypertension, because obviously you absorb that and then you might start to get hypertensive. But anyways, beauty tip, fun fact. But phenylephrine.
Same thing with Afrin and nosebleeds.
Afrin and nosebleeds, exactly. That's the other. It's in the active ingredient. And nasal the ones that aren't like Sudafed, it's the nasal decongestant. You'll see phenylephrine as like the active ingredient. So you take that, you absorb it, and it helps, squeeze up those vessels and decongest. So therefore, there's less edema there, right? So down below, if you've made sure it's not, a hemorrhoid, and you see frank blood, then you can kind of immediately think lower GI problem. The problem is when you have melanotic stool that's dark. Dark is not fresh. Dark has been digested. So dark is like, is it here? That went here and went through the whole thing, and now it's coming out my butthole, and I digested it? Or is it still lower but has had time to be digested? So melanotic stool is suggesting a GI bleed, but it doesn't quite fit the description. If it's frank blood, I know it's coming from down here, but it could be a higher low GI bleed or a very much an upper GI bleed that's just had the ability to go down and go all the way through, and now it's been digested, so it's that melanotic stool. Melana is the word I'm trying to find. So sorry. Sometimes when people text me, I don't know if it's you guys or okay, no. So melanotic stool. So we have ways to try to figure this out, right? We have an EGD, so we can look around the upper part, so we can see the esophagus, obviously the mouth, the esophagus. We can see the fundus of the stomach if they do a circumflex look, so they kind of look backwards and look back at the top of the stomach. They can look at the stomach. They can look at the pyloric sphincter, the cardiac sphincter, which is the one where your esophagus meets your stomach. They can look at all of these areas and see if there's erosion, ulcer, gastritis. Sometimes it's not like a huge serious problem. Like they might have melanotic stool. They just have some irritation, right? So the infamous sulcrafate or whatever that we use for vent ulcer prophylaxis, I've never seen this. I'm just telling you right now. But we give all these things to try to prevent that. So you might see these areas. So EGDs are able to look at this. You get through that. You go into the duodenum. Maybe you can see that. And then you can start seeing the top of the jejunum. And that's about as far as we can go. So, I don't think this is the area. We can also then look at a colonoscopy. Yay, bowel prep. So you get to give go lightly or something that's called like, what is it? Colon blow. Everybody see that SNL skit from like forever ago. It's called colon blow. But you're going to give something. All Go Lightly is just like literally pre-made Miralax, like just a giant vat of it. It's false advertising if you ask me. Go Lightly? No, it's go a lot furiously. Yeah, it's not Go Lightly. It's the opposite of that. And so bowel prep, and because I want to have that thing clean so I can see what the walls of that tissue look like. Are they dusky? Is my GI bleed secondary to an ischemic process that's happened, like mesenteric ischemia? We see that in the surgical service sometimes when people have issues with GI bleeding. Sometimes it's secondary to like an SMA clot that's caused an infarct in the bowel, in the mesentery somewhere, and now this part of the bowel is infarcted and now it's bleeding because it's dying, and maybe shedding part of it, its tissue. So colonoscopies. If you see something like that, they see that on CT. That's kind of a bit obvious. We don't wait for colonoscopy for something like that. Just kind of putting some of these pieces together for you. But you have a colonoscopy and you see the lining. Is it pink? Does it blanch? Sometimes we push on it on the inside. It's supposed to look pink. It's vascular. So, or is it dusky? Are there polyps? Are there polyps that are bleeding? Do we now have an incidental finding of cancer? That we never knew, and all of a sudden the patient's here for what looks like frank blood out his butt, and then we find that they have polyps in there that are cancerous or something like that. So who knows? But we know that with whatever the problem is, now we need to fix it if we can. So sometimes there's nothing to do. Sometimes it's just like, stop doing what you were doing. Add this PPI, add sulforaphane, just so we're all on the same page about this little one. If you see your doctor, order sulforaphane and something that's like some PPI or H2 blocker. Tell them which one do you want, because I'm not giving both, and it's not because I want to be lazy, but sulforaphane does not work when the other two are present, because sulforaphane needs an acidic environment for it to cleave the molecule to allow it to coat the stomach. So you're basically dropping a tablet in that's just doing nothing. So it's going in there, it's coming out the same way over there. All right? So do you want PPI? Do you want your sulforaphane? GI bleeding, the normal process for that to treat is always 40 of Protonics twice a day. We used to years ago do like the nice drip where you would run, it would be 25 cc's an hour, like day and night, just 24 round the clock, 24 hours around the clock. Now it's just 40 in the morning and 40 at night, and that's enough to consider treatment for that. Then they get in there and maybe there's like an ulcer. Maybe they need to inject epi. Maybe they need to cauterize and scar up that area. Maybe they need to take a biopsy. Maybe they're wondering if this is H. pylori causing any of this. Maybe they see something that looks suspicious for a cancer. I don't know. It could be a whole host of these things. Maybe they're, a really bad alcoholic, end-stage liver disease, and there's just varices like all the way down. There's just ulcers. I mean, all of these things, one of these things, 8 of these things. They can get through and look at the pylorus. Interesting enough, it's kind of funny we're talking about this, and I'm saying a couple of these things because I've been asking for some of my own education, and one of the surgeons, because I work in a surgical unit, and we deal with a lot of surgeries that we sort of rotor-rooter one's digestive system based on their problems, and some of them stem from adenocarcinoma, a cancer that you might see in the stomach. And I was actually saying, I want to kind of maybe put on a poster or something for the surgical area where it just identifies some of these things, because we rattle off a lot of surgeries, but do we really know what you've done inside? Not really. Does it matter to your CVP? Maybe not, right? But Doesn't it, wouldn't you want to know maybe what you did a little bit? So we have things called like a Bill Roth 1, a Bill Roth 2, a Roux Y. Some people have gastric bypass surgeries. And so I was actually looking this up, but it's funny because, you know, you get into the duodenum and we're talking about these GI bleeds, and maybe that this is stemming from a type of cancer, and maybe they see something from a biopsy that not only are we going to stop this GI bleed now with epi, cauterization, a biopsy, but also maybe we're getting ready to cut part of your stomach out and attach part of your duodenum to a different area of your stomach and do these Bill Roths or Roux Ys or something like that. So, or maybe they've been a GI bleed now and they've had this surgery before. So now, how does one get to those areas? So doing an EGD and knowing the anatomy is very important too. Obviously not our deal, it's the physicians, the GI service, but just having a concept that, you know, maybe their esophagus is their stomach already because they've already had esophagectomy. And so you think what you're going to go see down, it normally is not what you're going to see because their esophagus is their stomach now. So again, not for you to know, but just having familiarity with like different surgeries or different procedures. But when it gets to like those areas, when you pass through that pyloric sphincter and you see the duodenum and the jejunum, are there areas there that are of suspicion? There's I cannot think of the name of the type of procedure. It's the same thing. It's a EGD, okay? But remember I was saying sometimes you can have a low GI bleed. So it's melanotic poop coming out, not frank, but it's the lower part. So there's this procedure that I've seen done, I think actually only one time in my career, where what they do is they put the scope all the way through. So if you're familiar with what I'm talking about, and you do the EGD and you go through the pylorus, that's kind of looking like a worm thing, and now you're in the duodenum. You can get as far through that into the jejunum, and you're like, really, just barely in that jejunum. They'll extend this tube, because there's always this little tube where they can put like grabbers through, or biopsies, or stick an epi in there, or whatever. And they'll thread through, and they'll blow up a balloon. And it pushes against the wall further down. And as they pull the wire back, it pulls back towards them more of the jejunum. So now they're getting a closer look deeper into the small bowel. So sometimes if they're like, it might be in the middle, I can't see it high, I can't see it low, so it's got to be somewhere in the middle, they can do this type of procedure at the bedside. Like I said, not common. I've seen it once, and I can't remember the name of it. But it's the same thing as an EGD, but you're basically dragging backwards the bowel to look at it, and then when you're done, you just let it go, and it finds its way back. So treatment for lower, same thing. Does it cauterization? Do I need to stick some epi in there? Do I need to take a biopsy, cut out a polyp? All of those things are the same. So again, GI, they determine what they need to do. As far as you are, one, making sure that the treatment's right, the protonics, are we, if they've lost a lot of blood, is their H&H okay? Have we stabilized their H&H? Have we given enough product? When we think about product, now we got to think about all the things that come with it, right? If I give you blood, last week for anybody who was at my Q&A last week, we talked about that mass transfusion, and we talked about giving blood, and there's something very, very special that you really need to be constantly think about when you get, there's tons of things. I guess I want to ask if you can remember one of those things that I really identified as a very important thing to know, that if you do lose blood, you're bleeding. Alluding to this answer here, you're bleeding. And if I give you blood, I'm fixing the stuff that you've lost, but are you still bleeding? Maybe, hopefully not. But what do I got to do? What do I got to make sure you have enough of so I can make sure you can not bleed? Do you guys remember? Yeah. So look at Joss's answer. iCal. Calcium. So if you were to just sort of like pop on Google and type in the clotting cascade, you're going to get a ton of pictures. And some are very, very like basic. They don't have much information. Some are like very technical, a ton. If you kind of look somewhere in between, you can see like there's these common things like factor 2A goes to 3 and it needs calcium. If you have 7 going into 9, you have calcium. You have to have calcium to clot always along the way in every way, shape, and form. Boom, 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 boom. Okay? So if I'm bleeding, I've probably lost, well, one, the blood cells, right? Because bleeding has water, right? Blood has water, has the red blood cells, but has electrolytes too, right? So I've lost the red blood cells, I've probably lost the water, and I've probably lost some of the electrolytes, and one of them being calcium. But now I'm going to give you blood. So great, I open up the red stuff. For those who don't already know the answer to this question, I'm looking more towards these nursing students because I know nursing school does you an injustice, as I found out through my years. So I'm going to try to teach you some good stuff here. But have you ever wondered why when you cut yourself here and it's dry and it clots when it drops on the floor, yet we give this wet stuff that's out of the human body, that's also cold, just hanging in a bag, and that stuff's still wet? It's not a giant blob of a clot. I thought of that. Then I didn't ask because I thought, should I have known this in nursing school? Did I miss that? Am I an asshole? Do I not know? Am I dumb? But no one taught me, and nursing school sure as hell didn't teach me. You need calcium to clot. So there are clotting factors in that bag of blood, all right? It's packed mainly with the red blood cells, but there are clotting factors in there. So to not have it clot, there's this product called citrate. And citrate binds to calcium, and it makes it it makes it unavailable. Not gone, just unavailable. So I always use this analogy. You've heard it before, those, I'm sorry. But the little Easter eggs that are plastic, you pull them apart, you put like $1 in there and stick them back and hide them. Calcium, that's kind of how I think of citrate. It's calcium's in there. It's just you can't see it. It's not available right now. It's in those little Easter eggs. Okay? So they inject a bunch of citrate into the bag of blood so that there's no calcium that's available to clot. So it stays in its liquidy form, right? So you administer it in the liquidy form. Now, it's not this like exact 1-to-1 for every calcium I've identified in that bag I've injected. No, they oversaturate that bag of blood with a lot of citrate. So all that calcium is bound up and it can't clot. But there's citrate that's doing nothing. It hasn't had its job yet. So now you go put that in their bloodstream. They were losing blood. You gave them a unit of blood. But now you're giving them a bunch of citrate with the unit of blood. So guess what? That's binding that calcium that is in their blood. And now they might have a further risk of bleeding because they can't clot well. So one of the really key things here in helping this process is not just the administration of blood, but making sure the things that they need to clot are available. So we keep an eye on their ionized calcium, the thing that's not bound to protein. And you're probably losing protein here. You're digesting a lot of it. Talk about the renal system. You go draw a BMP, anybody that's a GI bleed, especially a really profound one, you're going to see their BUN, which is that byproduct of protein metabolism, right? That's going to be sky high. And that's because they're digesting their blood, which has protein in it, right? So it's like you just ate a cheeseburger. I guarantee you eat a cheeseburger, it tests your blood after, your BUN's going to shoot up. But then it's going to go down. You digest blood, your proteins, your BUN's going to go up because you just digested protein from your blood. So calcium is necessary to help stop the clotting, or stop the bleeding so that you can clot. So making sure that that ionized level is available. That's the stuff that's ready to go, right? And then obviously the factors. So like if someone was on warfarin, right? Making sure that they have available factors because that is working differently. It's inhibiting, so citrate, it inhibits calcium from being able to be used in the clotting cascade. Warfarin interferes with vitamin K, which is also necessary through that pathway. So one's working this way, one's working this way. So calcium will help with the citrate problem, but FFP is going to help with the coumadin problem. Also administering some vitamin K. So the ones that we don't quite have the best for are the Xareltos and the Eliquis. We give what used to be Profil 9, Kcentra, so 2789, no, 278 and 10, 278 and 279 and 10, or 278 and 10, if anybody remembers. It's 2710, I think it's 8. I think it's 8, 27810. Anyways, those factors, those are the ones, if you were to go what I just said and go on Google real quick, it will tell you which ones use vitamin K. So those are the 4 that would use vitamin K. So that's what you're sort of replacing. You're giving back those factors. If someone was in DIC now, like for whatever reason, now they're bleeding, you're giving blood, you're monitoring their iCals, and now, you're giving them their vitamin K, you're giving them their FFP, and for whatever reason they got sick from all of that, and now they're somehow in DIC, then now they're making and breaking little clots and throwing probably little micro emboli everywhere. And now because their body's like kind of, right, from this DIC process, they're probably now dipping in their fibrinogen. Like they don't have that much factor left. And so if a synthesis problem is occurring because of the DIC process, then you might even have to go that last step of doing cryoprecipitate, which is not usual. I'm just throwing that out there. If you were doing a mass transfusion, sure. If you're talking about just a straight up GI bleed, run of the mill that we get, no one's usually dipping into cryo. But I'm just kind of saying now we're going to an extreme of all of this. You need cryoprecipitate. Now you're looking at giving literally those purest factors, the fibrinogen, and that on our panel, which if you look at Steve Hayes, what our guidelines are, it's only if it's under 100, unless the docs talk and there's another reason and they duke it out. Nothing to do with nursing. But if the fibrinogen level is if a fibrinogen level is lower than 100, is when cryo would be utilized. So that's the extreme of it. Now in a mass transfusion, I don't know why you're being mass transfused, but you're getting a lot of products, is the general gist of this. And for the same exact reason, you lost blood, so I need to give you it back. I might need to give you platelets. I might need to give you the fibrinogen, which is cryo. I might need to give you the FFP, but I'm giving you everything that was in your bloodstream back. And you've probably lost electrolytes, right? And another thing to keep in mind with GI bleeding, and this is really anybody who is bleeding, not just GI, but just bleeding, is temperature. If you are cold, your body doesn't clot well. So you're actually promoting more bleeding by cold. So this is why if you've ever been a part of or talked about or seen anybody who has a code and we do the hypothermic protocol on them and we actually turn them into a popsicle and we're like 33 degrees, one of the things that you monitor for are signs of bleeding because their clotting factors aren't working. Their liver is not working as well as it once was. You rewarm them, that process comes back. It's better. It's not that they can't clot when they're cold. They just don't clot well, right? Other things happen.
Is it when you're cold, do you vasodilate? Is that why?
No, when you're cold, you try to vasoconstrict to conserve heat, divert blood, but to conserve heat. This is why people who, when you rewarm them, you see sometimes hypotension is because now that they're getting warmer, their vessels are expanding. Right? Okay. And people who are normothermic who might get a fever, they might drop their pressures too for the same reason, right? They're going from 37 to 40 or something. They might vasodilate, and you might see that on the screen as far as like an A line or maybe just cuff pressures and see like a drop. Now maybe it's not much, but you might see it, right? Again, we talk about this in theory. These are the things that can happen. Maybe they don't always happen, right? But so just as a general rule, every time you give like a couple of units of blood, you should always think about the calcium. If you're just given like one or two and like that's kind of it for the day, and there's really nothing else, it's like a patient, maybe they're waiting for IMC bed. I'm not going to go check an iCal. I just want to know that if something were to maybe brew after that, in my head, I think Chris Kurlansky asked this question like, what are the labs I should be thinking about for these patients? I'd be like, oh, well, I gave a couple of units and there's a bunch of citrate in there. I'd just be thinking about my iCal in the back of my head, you know? But if I'm doing mass transfusion, I'm always thinking about my iCal. In fact, I want to know it like every 5 seconds if I could, but often, right? Because of all that added citrate, right? So that keeps the blood wet. So drum roll, this is now for the nursing students. What product am I allowed to administer the blood with to go into the body? What solution?
Normal saline.
Normazoline. Okay, normazoline. So if I give you the normazoline, why? Why can't? What's in it? What's actually in that bag? There's 3 things in normal saline.
Isn't it like sodium and water and I don't know. I know it's isotonic. I'm not
Okay,
sure.
wait. I'm gonna help you. No one answer. You said sodium. 1. Water. What is it called? The name of the product?
Sodium chloride. Chloride.
Normal saline. What is salt? Sodium chloride. So if there's 3 things in there, sodium, chloride, water. This we could talk about the anion gap in a second if you want. But that has just those 3 things in it. There are other products that are isotonic, yes? I bet you if you take the time next time you go to work and whip out these bags that you just dump in people day in and day out, right? And actually look what's in there. Look at LR. What do you think might be in there other than the L, which is lactate, right? I bet kind of a guess, even if you don't know. I see you trying, Allie Cody.
Oh, I thought I was unmuted. I thought you guys could hear.
Oh, no.
I said sodium chloride.
No. What would be? What do you think is an ingredient that's in LR? That's not salt. What? How about the thing we've been talking about? Calcium?
Calcium.
Yeah. So if I add calcium back to the blood, what might happen to that blood that while it's running in? It might clot.
So this brings me, because I kind of was having a question, just going back to like the Easter egg like scenario.
Yep.
Of, because you said the egg itself would be like the citrate and whatever's inside it is the calcium.
Yep.
So like, I don't know how to phrase this in a way that makes sense of like what I'm asking, but like how, like what opens the egg?
Yeah, no, that's called metabolism. So citrate, so as it's in your bloodstream, as it goes into your liver, the liver will metabolize citrate and it releases back the calcium. That's why I'm saying the calcium's not gone. It's just not available. So if I was to put a unit of blood in you right now, you would see your iCal go like this and then like this. Because your liver, I administered it, I dropped, because there's all that extra citrate in your blood that's not bound yet because it's overly saturated, right? So it's just like hanging out doing nothing. And then you go and put it in your bloodstream and it binds to all that ionized calcium, right? So once it binds to it, it lowers your iCal. So your level would go like this upon administration, but you got a functioning liver, so eventually it would get broken down and your calcium would be re-released.
How
Simple.
like quickly would that happen? Like would
I don't know the half-life.
instantaneous.
I mean pretty quickly because if you if case you haven't put, I know like CNA wise, but you see a lot, right? So you probably hear us saying we're running a CVVH machine and we're on citrate, right? That is what you're administering into their bloodstream. But we're also giving an infusion at the end to sort of counter that. So it's kind of like almost continuous. So as long as you've got an okay liver, I don't know the exact half-life of citrate, but it's rather quick. you know? So you administer it, mixes in your bloodstream, binds the calcium, gets to your liver, gets cracked back open. Meanwhile, the next one's getting put in the egg because they just got sucked up into the system. And it's just this sort of like round and around and around we go. But if you don't add any of those components, just 1 unit of blood, you would drop your iCal, and then as your liver would metabolize it, it would actually come up and go past normal because all of that calcium that's bound in the bag, right? And so you would see a slight increase in calcium, and then you'd come back to normal as you sort of feng shui, take some of your calcium and you bind it to protein. That's why there's a total calcium on a BMP versus an iCal. Total calcium, Joss knows my phrase on this one. You'll see it in a second. I'm sure she'll type it. And you could be profane here. So the calcium. So why don't we run it with LR? No one gives. That's exactly it. That's my motto. So why don't we run blood with the other stuff? Because there's calcium in it, and you give the blood an opportunity to clot, and we don't want that, right? So what's in saline? Salt, so sodium and chloride, and water. There's no calcium. Ta-da! Right? Other than just being told, we don't do it, 'cause. Just 'cause. I wasn't happy with that answer. And hopefully now you could take that to nursing school and maybe shed some light, because I feel like they probably still don't teach it quite like this. So
Last year I had a simulation lab, and it wasn't my group, but like our group went after, and the students hung LR with a blood product, and that was like in the sim, like they had major clotting issues. That was kind of interesting that you were talking about that.
yeah. So, but it makes sense, right? Now that you're putting these pieces together. So that's why I say, like, I mean, the clotting cascade is like hard. I don't expect anybody to memorize it. But if you have like free time, I would say, click on, type it into Google, clotting cascade, and click on images, and you'll see, like I said, tons and tons, and some are very simple and some are just incredibly intricate, and you just kind of maybe start somewhere in the middle or even like low middle, just trying to see like, here are all the factors, and here are like the things that are part of that progression from one factor to the next in order to make the same endpoint, right? Because we also have intrinsic and extrinsic pathways. They have different starting points, but they meet somewhere in the middle, right? And then they get to the same endpoint. They make the clot, right? So but each factor, they all need calcium, but some need warfarin. They need, vitamin K. So anticoagulants, they interrupt something along the way there, right? Like heparin is a direct thrombin inhibitor, so it works way down here, versus these factors back here, which are vitamin K. They use vitamin K, so you interrupt that over here, but that ultimately disrupts the end product, which is the clotting, right? How long it takes for you to make a clot. So, and another thing that we talked about, Brittany actually brought this up last time, about what products, if you're doing maybe a mass transfusion, or maybe even not, maybe even just a bunch of stuff, but not quite as crazy, but still a lot, and you're just hanging it like normal. But like, what products would you want to give first? Is there always a sequence? And my answer to that is, there isn't something necessarily more important than the next, but I feel like it's important with the problem you have first, right? If I have a low platelet count, I want to get those platelets in ASAP, right? I need blood. If my clotting is a problem, I want to get those FFP in there. If I just have no blood cells, like no hemoglobin, I need to maybe get that in kind of quicker than the other stuff. You know what I mean? So kind of putting that into perspective of like, I might want to give that one first just because I feel like that's the more prominent issue right now. they're both problems, right? I'm bleeding and I'm losing my blood and I probably need to replace factors, but maybe my hemoglobin is 2 and my INR or something is like whatever, not too bad. So maybe get the blood first, you know. And also, I know that Tim Hayes has really been pushing this over the last few years, especially with mass transfusion, is trying to deliver products like you would in the bloodstream, right? So not just giving like 8 units of blood and doing them all together, kind of doing like a blood FFP, if you need the platelet, you know, making it like homeostasis, right? Like giving what looks normal to blood instead of doing like 5 blood first and then 2 FFP last. Like give them together, because I can't plug the dam if I don't put something in it. So if I give all my blood and I'm still pouring out, when are you going to give your factors? Like when are you going to give those my FFP, right? I need to put a finger in the dam. So if I just give you all my blood, I'm really not solving this problem over here. So kind of giving them together, you're making the volume of blood look like blood, but also making sure that you're doing everything kind of simultaneously, making sure their hemoglobin's up, they're oxygenating, making sure that you're plugging the dam with the factors. So another thing is, just so everybody knows, is that when you have a unit of blood, your unit of blood is not perfect. It's like, I don't even remember it, but it's not 100% viable, right? It's actually kind of on the lower side. I don't know the specific percentage. But you have a lot of cells that have been broken in there, right? And this is why in nursing school you get taught to make sure when you give blood, you fill the chamber with fluid above the filter so that as they fall down, they don't crack like eggs and you lose them, right? So you already have broken stuff up there. Why break more, right? Try to get as much out of it. But what's in those broken things? Eggs, right? It's egg. That's how I think of a cell. So depending on what you're trying to talk about, what is the thing that's coming out, right? So the whole host of things. One of them is potassium, right? So maybe I have to really watch my potassium as I administer a ton of product, because maybe I have all this this serum, a rise in my serum potassium because of it. And also, it's waste, right? They're broken. It's waste. My bilirubin, when the heme's open, my liver's trying to process that. So now I'm turning what is unconjugated bilirubin as I sort of break down heme into conjugated. So I might see a rise in those numbers. All kinds of fun things, right? Sorry, I can't sit still. Oof. Where are we at for time? I just don't even know. 11:30. Great. Is there more to that question? I mean, I feel like I answered a decent amount, but I don't know if there's more you want to talk about, or. Another thing, sorry, just to mention it, is that we have the Belmont, right, for the mass transfusion. I might have said this last time, I don't know, but the Belmont is so incredible, and it's so much better than the old level 1 that we used to have. This thing, self-primes. It won't give the patient air. Even if you never looked at it and it sucked itself dry, it will self-prime the air out when you hang new stuff and still never give that patient air. So it's amazing in that. But it also heats, right? And so as it warms the products that are going through, because we all know they're very cold, cold makes you bleed. So we want to warm you up. So if you have hemorrhagic shock, so now you have hemorrhagic hypovolemic shock, adding fuel to that fire is keeping them cold. So a lot of our trauma patients who come in and they're freezing cold because of blood loss, warm them up. So, but what do you get as a consequence to warming them up? Possibly. How about a loss in blood pressure? Why? Because you're vasodilating as you warm up, right? So just thinking ahead of the game, I might start to see a small drop in my blood pressure, or maybe even a vast drop in my blood pressure, because as I warm them up from their trauma, and because they were freezing cold, we're giving them the transfusion, so we're trying to fill the pipe up with blood and FFP, so whatever the products might be, that we might lose pressure just solely on the fact that we're rewarming them because they were so cold. But they might clot better now. So all kinds of things are so intricate, You said, spread the word. I find blood dripping on the filter all the time. Blood dripping. I think. Do you mean through blood dripping on the filter? Like it's clamped and it's still dropping into.
Oh, here I am. Yeah, all the time. I find people don't cover their filter and there's blood or platelets dripping on your filter.
Oh, you mean when you first prime?
Yes, all the time.
Yes,
I say this to people and they look at me like I'm making up stories.
No, and it's interesting. I have that same passion about it because all the people I've ever oriented, I know they probably look at me crazy when they look at me crazy all the time, but they look at me crazy because I'm like, I'm going to show you how to prime this tubing. And hold on, I'm going to mute you just for a second. I'm sorry. Just so I don't hear the reverb. But to prime it, right, a lot of times we use that bolus tubing, the blood tubing, just to give a fluid bolus, right? But I do these things that make it so I don't forget. It's kind of like, why do it this way for one thing and do it this way for a different thing? And then you might forget. How about do it the same way for either way? So I know that when I give blood, I always have to take the saline and go squish, 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 and I make it rise above the above the filter. Then I give the blood, right? Then I have the blood start dropping down, and that water level, that saline, the meniscus of the saline is well above that filter line. But when I just give a fluid bolus, I still do the same thing so that I don't ever not do it, right? So even I'm giving fluid, I do that stupid U thing that I show you that Joss had forever. They all do the same thing. They all stumble with it. But you make the U and you get the fluid priming through, and then when I'm done, I go squish, 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 and it's always above that so that I never do it. And it's the same thing. I mean, this is totally not the same, like this is a different topic, but it's kind of like when I say after you move a patient, you level a patient. People go, what? That way you never forget if you have a transducer that you needed to level it. So just tell yourself to level the transducer every single time so that at the times that you do have it, you don't forget to do it, right? It's like a game with myself. So I always like fill it, even if it's just a fluid bolus, above the filter so that I don't ever forget to do that. It's just a habit. I don't even know I'm doing it. I go, scriptures, and I watch people go, why did you? I'm like, just cuz. Let me do it. Sorry. So Alana had mentioned the blood parts. Yeah. So cryo, really, and the platelets you want to administer. So if you ever see the tubing that the Belmont has, at the very kind of like the patient line that goes from the machine to the patient, along the way there's this clave that's built into it. And that's where you can plug in your platelets or your cryo so that it goes directly in the patient, doesn't get gummed up or clogged up in that filter and become caught up here and never get there, right? So those ones you want to put down there. Sorry, I'm just trying to read. Platelets, yes, and one more. Cryo, bingo, we just need to educate. Yeah, no, all of those things. So it's a fun device to use. I love it. And it's just, I've already used it with a patient who needed a lot of blood, but I was actually doing the whole thing by myself because I didn't have to worry about air, and that you can dial how fast or slow you want it to go in, and you can add fluid with it. You can give all three products at the same time, like your fluid, your FFP, and your blood. You can give all three bloods if you want, and you can have it go in real fast. The other beauty of it, if it works, recommend taking all your claves off the device you're about to plug it into, because the pin that pushes the piston back out can add pressure, which makes the machine think it's has too much resistance forward. So that's one key. And sorry, I had a brain fart. I can't remember the other thing I was just about to tell you. But that's one thing. It will come back to me. But what else we got? Oh, good. Yes, all good things. It will come back to me. Sorry, my brain farted. So excited. How's everybody doing? Do we want like a little break, like a 5-minute break or something, 10-minute break? Pee break? Anything? Anybody? Okay.
Do you need a break, Mark?
No, I'm good.
Okay.
I've just been peeing on myself. Don't worry about me. No, I'm good. I just.
Yeah, you've got your leg bag for this.
Yeah. No, I just wherever people are at. So we talk. Is there something else about that people have had a thought, or maybe you had practice with? Know that you get the coolers, the green coolers. When you do a mass transfusion, there should be sort of one identified communicator to the blood bank, so that you're not saying this and then the doc told someone else and now they're calling and then all of a sudden it's just all hell breaking loose. So they really appreciate an identified person to be in charge of who is communicating. Do we need a new cooler? Do we not need, like, what are we doing? Are we still doing this? So that's very important. And every time that you do you finish a cooler, there's blood work or lab work that's in there that needs to be sent. So if you finish the cooler, you do that. Or if you end it and you still have product there, you can return the product to the blood bank, but that lab work should still be done.
And just another hot tip.
Yes.
The lab work comes in a green bag, and that green bag supersedes a stat bag to the lab. So the lab knows that that green bag is for massive transfusion, and will override it for a stat bag. But that's the only thing that overrides it. It's the only time we can get a green bag, because I try to get them to let us stock it up here, and they won't.
Okay. No, that's a good tip. I knew it was like a pass. What's that?
Hey, am I unmuted? I can't tell.
No, I can hear you.
Okay. So another thing to just be cognizant of is that when you're in a mass transfusion, one person in the blood bank is pulled out of their workflow and is in charge of that mass transfusion. So if you have a cooler with like 3 bags in it just sitting there for 2 hours, it would be really beneficial to the blood bank staff if you mass transfused, because that person does nothing else other than control that cooler.
Oh, that's
just
good to
FYI.
know. Yeah, I don't think I knew that at all.
Yeah.
Sometimes,
and then,
the doctors,
some people will be like 12 hours with a cooler in their room and they haven't given a unit for 3 hours, and that person is still kind of on hold. Just FYI.
Yeah. Oh, another just more like fun fact about the filter. So when the rep came like a few years back, this is like military type equipment, right? That's why there's not a lot of gears and stuff that can wear and tear. That's why it's very much like plug and play kind of stuff. So anything that doesn't have to move, it's going to last longer. So they stockpile this type of tubing, and that filter system is actually good for 150 units. But we, as in the healthcare, have identified 75 units. So you should really only need one filter to do this whole job. And if you look at ordinary tubing, the idea is 4 units, 4 hours. So whichever comes first. With this, we just kind of like keep on going, right? But speaking to what Judy just mentioned, sometimes I feel like, we get the patient stabilized, and we might have some units of whatever left over. And then the question is like, the doc's like, I don't know, like, I don't want to call it yet. So I feel like now that I know that, I might be pushing that issue just maybe a little bit more, to say to the docs like, hey, listen, I know you're feeling like a little strained. I feel like the patient's been doing well. Why don't we call it? And then if something happens, we'll just reactivate the mass transfusion. That way this guy can go back to better workflow. So something like that, it's important to know, I appreciate that learning opportunity. See? It's not just you guys, it's me too. What else do y'all want to talk about? What are we feeling? Anything come up recently? There's some new people. Are there new people? No, everybody's the same. Sorry, thought there was a new name. How's it going in Neuro World over there? For you, Josie.
Sorry, I think doesn't work if my headphones are in.
Oh no. I was thinking about the vent stuff and how much we were talking about hypoxia and hypoxemia, and you guys have to have the upward battle of ICP problems. So you must be able to relate a lot about this. And I don't know if you have some. I know you have like the Rumetic or Pneumatic or something that is like the Lycox thing I was talking about. Yeah.
Yeah, I hadn't heard that word that you said before because I've only seen the Bolt or the EVDs, obviously.
Do you guys still have the SAT probe thing?
Josie, how frequent are bolts in SKU3? Do you see them like a lot? Because I feel like it's like a rare case. Like, I don't know. I just feel like I never hear the word, and then all of a sudden I hear it, I'm like, ooh, they must be really sick.
Well, I think we actually see them a decent amount, and we were doing like a research study on them a little bit ago, so I thought we were seeing them more. But
yeah, I kind of remember hearing about that.
What is the difference, Mark, between the Bolt and what you said?
So the Bolt is really meant to look at ICP.
Yeah.
Just give you that information about the pressure.
Mm-hmm.
The Lycox has nothing to do with pressure. It's literally a SAT probe. It glows red like your finger probe, but it's like a long kind of. Just think of like like the inside of the pen. So they put this piece inside the brain. So they have to make another hole, put that in there, and then the little SAT probe is like at the end inside contained. And so it just looks at the oxygenation that runs through that area. So it's an oxygen.
Can't you get your PbO2 off the Bolt as well?
No.
Or am I thinking wrong?
We didn't. I mean, I don't know. Like I said, I don't know the equipment you used today, but back then.
Molly, what do you say? I guess
Sorry, I couldn't figure. Yes, the Rumetics, yeah, you can, or the bolts, you can see the PbO2 and the ICP.
So is it just a newer version of what Mark was talking about, or?
Yeah, I'm thinking the one he's talking about was just the PbO2, right,
Yeah,
Mark?
that was the old Lycox. So they would look like a bowling ball, literally, if they started with the bolt, wanted the Lycox, and then realized they wanted to drain them. Because that's the downfall to the Bolt is you can monitor, but you can't drain unless you guys have some new thing there. So if you want the EVD, that's great. So these guys sometimes, maybe they started out not looking so bad. They're like, oh, let's put a Bolt in. Maybe we'll also throw a Lycox in. So that's 2 holes. And then they decided that over here they're going to throw an EVD. So literally like right down the alley, right? So yeah, so the equipment that you use today, I'm assuming it gives you the same information, but the style in which it's like what the capability of the devices are different. So unless your bolts drain, I'm assuming your bolts still don't drain. It's just ICP information only. So I always found that really weird. Like, so you're gonna crack into their head, right? You're gonna go through through the bone, right? You're gonna drill that hole. So why just a bolt? Because it can't drain. So if you want to drain, it's like you got to do this other whole process. To me, it was like, why not just put EVDs in everybody and like screw the bolt? But then there's obviously rationales for that. So that's why they get paid like $1 bazillion a year to make those decisions. I just get to look like, huh? So, but yeah, but I'm just going back to the vent stuff. When patients are there, have you ever seen with your, is it Rumetics, like Rumetics or Rumetic? Okay. So when you have that device and you have your SAT or your PbO2, have you ever done what I described earlier, which is like chasing someone's PbO2, and you're pushing these numbers that you would never do for anybody else, right? Like you would never get somebody's crit to 30 or give them a hemoglobin of 10. You would like laugh at that. But this patient you would. So you're like dumping in a lot of blood. Your positioning changes. Obviously, you're sedating them. You may be paralyzing. Who knows? Obviously, the pen coma kind of thing. But now you're stuck having to go way up on FiO2, but like not really wanting to touch that PEEP. And then maybe anything bad as a consequence. Or have you not had that experience yet? Or anybody that works out there?
Yeah, I personally haven't had the experience where then I see something bad happening with their lungs and maybe I just like didn't take care of the patient long enough to see that change. But it really was exactly what you said, like when we were doing that trial, it's the boost one that Alana said. You had to like mark what you were doing in order to get that PbO2 up. And it was exactly what you said, like one option was position them differently. One option was increase the FiO2. So it was, yeah, all that you were saying.
I still remember some stuff. Woo! That's good. I mean, Molly, you work out there. Have you had any of that type of experience as well?
Do you mean like when you're trying to get like a PbO2 higher?
Yeah.
And I haven't, like, kind of like Josie, like I feel like it's typically pretty quick when you, like, at least the patients I've had, you just put the FiO2 up just a bit and it takes some time, but usually you see the PbO2 come up and then you can end up, or, you know, the ICP come down, PbO2 go up, and you can typically wean them back down on the FiO2. So I haven't seen them develop ARDS from it.
Okay. That's good. I mean, it's great for those patients. It must be the beds. Just kidding. No, it's great. The scenario I described, I wouldn't say that was happening like left and right or anything, but I will tell you that it was definitely something I saw a few occurrences of, and you know, but not understanding it maybe then, but then like as I've learned, it's like, oh, we were doing that, you know, we were chasing that one number. And that's why I say, like, everything else about that patient was fine. Everything. He wasn't here. He had no pneumonia. His lungs were clear, crystal clear day one. And, like, 3 or 4 days later, it was like, I couldn't hear a thing. He's on 100%. PEEP of maybe 8, I think, as far as they wanted to push it. I don't think they went higher. And the guy was having, like, terrible lungs. And then we had to change it up a bit and do some other things. And obviously, you know, as time went on, we were able to shift it and come back and get him better and stuff. And this was all because of a TBI, just a TBI, you know?
I will say...
Oh, go ahead.
Oh, sorry.
No, go.
No, I was going to say, I had this really... I'm remembering now. I feel like it's been forever, but I think she was the first boost trial. That's the trial we've recently done with bolts and traumatic brain injuries. Basically, I think she was like in a motorcycle accident, and she came back from the OR, had a bolt and maybe like a subdural evac or something. She was really sick, and just like her hemodynamically, Brittany was there with me, thank God. She was like saving me. She was just like, her blood pressure was high, and then all of a sudden it was low. We were about to push epi, and then all of a sudden so anyway, and then I just remember her PbO2 was dipping, and the FiO2 originally was helping, and then all of a sudden she was on 100%, and her PbO2 was still low, and her ICPs were climbing, and we ended up, like, since her hemodynamics were so unstable, we ended up, I think Linda Gardner was the one, like, saying, like, I think she needs a positive inotrope, and that ended up helping, and I think they started Debuta or something, and yeah. So then we could come down the FiO2, and then we didn't end up getting ARDS.
Nice.
Yeah.
So right there, that tells me that the patient had some pump function issues.
Yeah, I think she developed some Takasubos from the brain injury.
Got it. So I mean, and when you say that, then that makes sense, because when you have somebody who has a mixed venous gas, or if you actually have, you know, the SVO2 from a SWAN instead of like the triple lumen, and you were able to, you know, get that data, and it did come back low, that might very much suggest that the extraction's just sort of happening, but the blood isn't really moving around, which means your pump is not so great. So giving it better inotropy, contractility, better push, better blood flow around the body, you have the same amount of extraction, but now you're moving it around. So that's why if you ever see the SVO2 or mixed venous come back low, it very often suggests that it's a pump issue. So Takotsubo, the old octopus, right? Global hypokinesis, I believe, is the terminology. So makes sense. And then, the interesting about Takotsubo, I really don't know much about it. I've only had like a couple patients that had it through the years. But I remember, I think it was actually maybe my first one with Rich Riker, and beta agonism is actually like terrible for it. And so I had a patient who was like on norepi, and he's like, turn it down, like get it off. And I was like, but his blood pressure's not that great. He's like, it's because it's that. I'm like, but I can't turn it down because the blood pressure. He's like, turn it down. I'm like, I can't do this. You got to do that. I cannot touch that pump. It goes against everything I stood for. Like, but it's kind of, to me, it was like that counterintuitive process, like when someone's tachycardic, like an RVR, and they go and give you low pressure and they're hypotensive, and you're like, ugh, I don't want to do that, right? But like, you actually kind of do want to do that. I mean, you should do that. Hopefully, you should.
It's funny, Mark, because I had a patient who was super septic one night, and I was on like 3 pressors getting ready to add my 4th.
Can you speak up just a little bit?
Can you hear me now?
A little bit better.
Kind of. So I had a patient who was super septic, and I was on like 3 pressors, and I was getting ready to add my 4th because she just like wasn't, her blood pressure just was awful. And Nora Chung came in, and she's like, turn down your norepi. And I was like,
you're like, no,
I don't want to.
No.
And she's like, turn it down. I was like, but I really don't want to.
Yep.
And she's like, I'm right here. Turn it down. It's okay. And surprisingly, when I turned it down, her blood pressure actually like got a little bit better because I wasn't like squeezing so much. And so at the end of it, it made sense. But when you're standing there, they're like, turn it down. I was like, no, I don't want to.
It goes against everything you've ever done.
Yeah.
Yeah. It makes your sphincter pucker a little bit when people tell you that. Yeah, just shut it off. You're like, no, they're on jet fuel. No, just turn it down. No, I can't. So it's, you come across these cases and stuff like that. I love these types of scenarios because it's like, this is new, this is scary, it's exciting, I'm learning something, I shit my pants maybe, but patient survived, and now I got something out of it. And then when you sit back and kind of think about it, you're like, oh, like I'm getting that. I don't have a clear understanding yet, but I definitely have some more than I had before. So I can't say specifically I've had that many patients with it. I know I've come across a few, but personally I don't think I've had that many. But what we do get a lot of is just the general stunned myocardium secondary to sepsis that you get, but that actually does respond to beta and alpha, beta being the inotropic and heart rate chronotropy, and is effective. And that's the nice thing too about if you want to take like a little sway in our conversation here and talk about sepsis, I tend to talk about the heart rate thing because it just goes to what we were just saying about something being counterintuitive, and that is when you have somebody who's tachycardic for a specific reason, not from being scared or something, but like one of their shock states, right? So you have hypovolemic hemorrhagic shock, or you have your septic shock, and you have this tachycardia, right? Well, the tachycardia is the compensatory mechanism for that loss in cardiac output. So when you lose your cardiac output, you've lost stroke volume, right? If the blood is not there, or you're vasodilated, you third spaced, and the SVR is gone, in all of these scenarios, do I have a loss in preload? So if I lose preload, I lose the stroke volume. So if I lose stroke volume, the next thing in line is a lower cardiac output, which means low blood pressure. So cardiac output, heart rate times stroke volume. So the next thing your body says, well, if you lose this, I'm going to make it up over here with my heart rate. So heart rate going faster in the loss of preload is a good thing. It's a great thing. It's a compensatory. It improves the cardiac output, and you get good flow. And why do people always go into renal failure or have a renal injury in most of these states? Because 20% of your cardiac output goes directly to your kidneys. So the first thing in line when you poorly perfuse your body are the beans, all right? So that's why that always tends to be a thing that occurs. But when you think about this compensatory mechanism, this idea is universal, but the point is always different for everybody. So if this is like X and Y axis, X, Y, and it really doesn't matter if you can't remember which is which because they're interchangeable, but they kind of speak to the same point. So whether that's cardiac output or heart rate or vice versa, it doesn't matter, right? All I'm doing is the CO and HR, and just draw a lovely curve, right? And that curve is going to be your cardiac output, all right? Right at the top is that crest, right? It's beautiful. It's where all the magic is going to happen. So if you lose your cardiac output, your heart rate is going to speed up more and more and more and more and more to compensate for that loss in cardiac output. But if you go too far, you have a loss. Why do you have that loss? You have that loss because you don't allow for enough time for the ventricles to fill. So where that point is different for everybody, but the point is that tachycardia is necessary, right? But eventually it can be too much and actually worsen the scenario. This is why it's counterintuitive when someone has a super fast heart rate and their blood pressure is low, whether it's a tachycardia from sinus or if it's an AFib or whatever, but they're like here and they have a softer pressure, right? And then someone says, well, let's give them 5 of low pressure. And you're like, ugh, no, I don't want to. And then you poop a little bit, right? Well, let's take that poop fear away. If I rate control them, they're going to come back up that curve and they're going to have more time to fill, which means they're going to have a better cardiac output again. So just like the Takotsubo that we were just talking about and taking away the norepi, and you're like, it's like, I don't want to give them low pressure when they're in this position, but actually you do. This is why that works, is because I want to decrease the heart rate so it can have more time to fill. But there is that point. So too low of a heart rate, not good. Too fast of a heart rate, not good. So where is that for? It's different for every single patient. You don't know. There's no magic number. Like a heart rate of 143, boom, 144, dead. 142, okay. But 143, no, that number is always different. So you see the effects of the blood pressure as things happen, right? So I wanted to speak of that because that ties into that Takotsubo that you were just talking about, like as being something that seems counterintuitive. But the thing about the pressors is that when we reach for these drugs, right? If you want to talk about all the pressors on a very, very fundamental level, like kindergarten level, you turn them all on. If you were to hang all of them, right? And you didn't know which one that someone chose. It was like the mystery drug, but it could be any one of the norepi, the epi, the dopa, the phenylephrine, the vasopressin, any of them, right? You hang them, but you don't know which one it is. And all you have on your pump is the word up and down. That's it. No drug dose, just up and down. You turn any of them up and your blood pressure goes up. You turn any of them down and your blood pressure hopefully doesn't go down, but it might fall or drift or whatever, or go down, whatever, right? But we all get the point. But they all have a different method of how they get to the end point, and they all have other effects. So sometimes you either want those effects, don't want those effects. So when it comes to when you were talking about the dobutamine, the nice thing about things that have beta agonism, this is actually talking to the nursing students again, because in nursing school they drive home that beta 1 is heart rate, right? Always rate, but they never mention that it's also inotropy. It's the contraction. It helps with force. So through beta agonism, do I get a better heartbeat? Not just the rate, but the beat. Like, it's the inotrope. This is how dobutamine works. It stimulates beta. It's very pro-arrhythmic as well, but it stimulates beta. So the reason why I drew that curve is that when people are in shock, like the hemorrhagic or in the septic shock, they're already compensating with a fast heart rate because of the loss of cardiac output. So then you give them their blood back, or some blood, or some volume, or whatever to fill that pipe back up. But they're still like in this dilated state or loss of blood or whatever. They're not like they're not fixed, right? But they're getting better. But they still have this fast heart rate because they're still compensating. Now, if I give them volume in either crystalloid or blood or whatever, that should help improve the overall intravascular volume, which means better preload, which means better stroke volume, which means hopefully a decrease in heart rate, right? Because the cardiac, better stroke volume, better cardiac output, which means my heart rate doesn't have to compensate as fast or as much. But even if I'm in that like kind of quasi-tacky area, like maybe when they first came in, they were $150, right? Then we give them a few liters of fluid. Now they're like 120. Why do I want to give them a drug that's going to stimulate beta to make them 170? No, I just going down the curve, wrong side, right? So how about give them something that's inotropic and squeeze, right? But not like chronotropic. I don't want to pull out epi for these patients. Why? Their heart rate is going to go to like 500. I just want some contractility, and I want some squeeze, right? Especially in these septic patients. That's the ones that we deal with like a lot of the time, you know? So I don't want to push them back up and over that curve. So the beautiful thing about norepi is that it has beta agonism. It helps stimulate the heart rate to go maybe a little bit faster, but it's working also with inotropy. And then it's giving you the squeeze that you're looking for, which is increasing or improving SVR, which is your afterload, right? And then through all of that magic, do you have better preload? An increase in CVP, hate it, right? Because you put more blood back there. All I've done is diverted blood from here, put it there, so if it's filling more space, CVP is going to go up, right? Trashy number. But you can see, like, the diversion of blood, better preload, better stroke volume, better cardiac output, lower heart rate, better blood pressure, better perfusion. Beans are happy, kidneys are happy, hopefully everything else is happy. Your foot might be black, but everything else is happy, right? Hopefully not your foot, just kidding. But so that whole heart rate, like thinking of that, like you don't have to worry about remembering which one's which. Just remember like this bell curve, right? And smack dab in the middle somewhere for your patient is a good heart rate, but after that is not a good heart rate. And so you have a process that's probably prompting or promoting a fast heart rate to begin with. I might not want to give you something that makes that worse. But sometimes I need to give you something that's like that. So epi is great. No one yells for an amp of norepi when they're coding, right? I want your heart rate to go fast as faster than mine, and it's already beating at 500, right? Because you're dead, and I'm scared shitless, and once again, a poop moment, right? So here we are, I poop myself, patient's dead. I want to speed up their heart rate. It's either 0 or it's 1, and I want it to go faster than 0 or 1. So I reach for something that's really going to work on chronotropy, right? I really want to maximize chronotropy. And then through that is inotropy and squeeze with the alpha receptor, alpha 1. So all of those things together. But when I'm sitting here just from sepsis, I don't need all that. Now, that doesn't mean that you won't have patients who have multiple shock states who then do need something that doesn't normally follow suit, right? I might have a patient who is septic who needs epinephrine. Why? Because they're in cardiogenic shock as well. And through epi, do I get better inotropy outside of just giving them something like dobutamine and milrinone? So I might want that epinephrine for that patient, because I do get better flow. I do get better oxygenation and a better SVO2, which means my pump is functioning better. My EF might have rose. My stroke volume might have been better, right? So the end diastolic ventricular fill, I might have more blood get in there because of the better preload. Like, all of those things would improve. But that's not the norm. That's the thing, right? But again, going back to kindergarten, if you don't know which drug it is and all you have is the word up and down, we know that they all do the same thing, right? Eventually, hopefully. So that was a nice little tangent. Where are we at? We're at 12:10. Does anybody have any questions? I mean, we've been talking about some. Okay, I've been talking about some stuff. But has anything else come up? Brewed a moment, a patient that you might have had. Maybe you had a swan. You know, those things that go. That maybe you had these drugs, and maybe you had the continuous cardiac output swan. So maybe you had these drugs live and you got to see information live rather than once like a Kodak moment, and you got to titrate these drips and maybe saw numbers change according to how you titrated. So what I mean is, like, you know, if I know that epinephrine makes my cardiac output go up, and I have a swan and I have real-time information and I decrease that dose because their blood pressure is better, do I see their cardiac output drop a little bit, knowing that if I take it away, there might be a loss in cardiac output? You know what I'm saying? It's like affirmation to like what you already know about your drips, any of your drips. So has anybody got to play as much as that? Or even as something as simple as the flow track, do we need to go over what that flow track is? What are those numbers? Because, you know, we spout off a lot of the same numbers between the two gadgets, right? The PA catheter and the flow track. And we're recording it hourly, and we always say it doesn't matter because no one treats the numbers, which is mostly true. But it has information, and it's supposed to mean something. So does everybody know what that information is? I mean, the PA
Could you go over like the numbers
for
and
the
like
flow track?
the flow track? Yeah.
Yeah, absolutely.
Please. Thank you.
Yeah. So there's 7 numbers that you're always recording, right? And 5 of them I like, 2 of them I don't care for. Not for the same reason though of the CVP. It's just because I never got taught this, so I don't wrap my head around thinking like this. So I'm going to teach you my style. If anybody has information, you can teach me. But we're going to start with the easier ones. We got the cardiac output. Liters per minute, right? So we have this amount of blood shoots out of my heart every minute and hopefully keeps me alive. Pretty basic, right? Normal, around maybe 4, if you're a really big guy or something like that, or girl, like 6, but usually it's like, I would say 4 or 5 liters. But the cardiac index is, I feel, what's mostly important. Now, you have to have an output to have the index. But what the index does it's like that universal. We were talking about PEEP. We're trying to tie in some concepts. So if you understand something, maybe another thing might make you understand something else better. So we said for PEEP, the 5 is that universal number, right? But the volume of air is different for everybody. So 5 is 5 is 5, but you might have 50 cc's, you might have 100, but the pressure's 5, right? Cardiac index is like that. It's not a pressure. What it is it's liters, but it's liters per meters squared. It's based upon how big you are, that body surface area. So if you're 4 feet tall and the other person's 6 feet tall, they need the same amount of blood to go to all their tissue. But the person who's 4 feet tall does not need 5 liters. They only need like 3, right? But they need an index of 2.5. The guy that's 6 feet tall might need 5 liters to get the index of 2.5, right? So the liters are going to be different, right? There's kind of like the general appropriateness of how many liters do come out of the heart to perfuse, but the index is telling you, is everything being perfused? So that's how I'm trying to tie in another concept. If we're understanding what that PEEP is, you can maybe apply it in this sense, right? That the thing that's the consistent number. So an index of 2.5 is the same for you, and me. But I might need 5 liters to do it. You might need 3. You might need 2. You might need 5. I might need somebody who's so vasodilated to get 10. Right? They're so vasodilated, like their artery is this big, and it takes an ocean, one giant ocean to go through to get that cardiac output to look great so that they're perfusing, and their index is 2.5, right? So how many liters does it take to perfuse the entire body where the index is how that works, how that translates over to your index? So to me, you need one obviously for the other, but the what's important is that index is okay. This is why like 2.5 and above is great. That's what you aim for. In our world, realistically, it's mostly 2. So if it's less than 2, at least try to get it up to 2, but get it to try to go to 2.5 would be even better. But at least past 2. So you use inotropy to fix that, right? Plus squeeze. I mean, squeeze ties into it too. If I'm spitting into the wind, of course I'm not going to get any pressure anywhere. So I need some squeeze, right? I need resistance. But I also need the pump to be able to pump forward and pump well. So when it comes to those two numbers, that's kind of how I think of that. The next one is your SVR. Well, I need resistance to make pressure. If I don't, I won't get it. Again, if I spit into this my dining room, what is the pressure in this space? Nothing. There is no pressure. Nothing changed. A little bit of spit. So I need to fill this whole environment up with something so the walls get touched in all directions, and then it wants to force back in upon itself, which generates pressure. So I need resistance to make pressure. So you do have to have some resistance, right? It's just I don't need a lot of resistance, but I don't need not enough either, right? So when we talk about SVR, we always talk about 800 to 1200. So when you have patients who vasodilate, and the greatest example is septic shock, because that's a vasodilatory distributive shock state, then you vasodilate, your SVR drops, and now you're looking at pipes this big with the same amount of volume. So now it's the pressure's terrible. And also now I'm leaking out because of capillary permeability. So I really have a lot of volume loss in the same size pipe. So I either, again, have to fill the pipe up all the way to generate that pressure again, or I have to squeeze it down, which is what we tend to do, right? We tank them up first and squeeze them down after. So with SVR, you want to try to get back up to those numbers or closer to those numbers, because that means I have better squeeze distally or peripherally, right? So improving afterload, right? That resistance. But remember, increased SVR, if you go to the other extreme, is making the heart have to work harder. It's like trying to push your hand through the curtain in your room or against the wall, who is going to be a little bit easier to move? The curtain, right? So the curtain is like a low or normal SVR. The wall is like an extreme SVR, a higher SVR. I'm going to have to work harder and harder and harder to get that wall to move, right? So I end up using more energy to try to move that. So why not just turn that door into a curtain? Then my job just became a lot easier and I don't have to work as hard. And more stuff will get accomplished, right? I.e. ejection fraction, blood out, stroke volume, right? I'll improve all those things. So the SVRI, this is the one I don't talk about because I don't use it. We record it. It's just like the index of your cardiac output, but based upon your squeeze. I literally can't talk about it. I don't even think about it. I've never got taught about it. I would have to like actually do my own research about SVRI. And the same thing goes also with SVI. So I'll talk about SV because that's obviously the one we all know about. Stroke volume, right? That's how much blood is leaving that ventricle, right? So there's got to be a certain volume that gets into the heart or into that ventricle, and then it's got to go out, right? So the stroke volume, how many cc's? Literally, how many cc's went, right? So if I don't have a lot of preload, my stroke volume is going to be very low, right? But if I fill you up, I tank you up, better preload, more volume will fall back into that ventricle, and then you'll have more stroke volume to leave, right? So it'll improve that cardiac output that way. So literally cc's. SVI is like dynes per second squared or something. I don't even know what a dyne is, but it's a thing. It's a measurement of who knows what. Resistance, I know, but it's like that's physics. This is my endpoint on physics. But I don't speak about the SVRI. I mean, it's obviously it's an indexed number, so it's relationship to your body mass, right? So it makes sense. But I don't like logically, I don't process, I don't think about it. I don't see the picture of how this affects me and my care. I think about the SVR. That's how I've always learned, and that's what I'm going to teach you guys. And the same thing goes for the stroke volume. The stroke volume is that volume, but it also is an index number. Can't speak of it. Don't use it, don't care about it. Tomorrow, if I find out something amazing, I might change my mind about everything I just said. But for now, I hate it. I don't care about it, and I don't know anything about the SVI. But yet again, an index number based on the stroke volume, and then I don't know if it's metered squared, but about your body size, right? So then the one that stumps everybody is the SVV, so stroke volume variability. Sorry, I'm so bad about reading these things off to the side. It's like 10 years later I see it. Okay, that was from earlier. Okay. So SVV, stroke volume variability or variation. So it's talking about variation, moving, something that's not still. And it's talking about stroke volume. So we're talking about that blood thing again, right? That goes into the heart, the volume that falls into the ventricle. But it's variable. What does that mean to you? It means it's changing. It's not the same. So how I always have imagined this, because again, I don't understand things by words, but I get imagery. And then I see the image, it's like, got it. How I always look at this is like, you take a garden hose, two of them, identical, right? And they both are at the spigot. And you take one and you turn the knob just a couple turns, and you see the water coming out the other end. But it's not like rushing out. It's just like it's a nice, steady little dribble, right? So if you were to go over to that garden hose and touch it or stand on it, it's probably going to go, right? Squishy. But if I could take the other garden hose and I turn it and crank it full blast, and the water is just gushing out the other side, I guarantee you step on it or push it, it's going to be really firm, right? It's not going to give very much because a lot of stuff going through it. Fast, hard, right? So how I look at it is that when this has to be done on positive pressure for this to work. So just as a side note, when you have somebody who is on the flow track, you will get numbers no matter who they are or what's happening, whether they're intubated or not. But what I'm trying to tell you is that for the numbers to actually have meaning and be accurate, there has to be like a few things in check. One, you have to have an A-line. And it has to be functioning, not this stupid, constantly positional crap. So that never happens. Then they have to be in sinus rhythm because it has to be a regular pattern. So if they're in sinus but with tons of ectopy, that's going to throw off your numbers. If you're in sinus but you're greater than 120, it starts to throw it off because it can't calculate it based on its speed, right? And you have to be on positive pressure. Why? Why not negative pressure? Because when the vent is pushing in and it changes the interthoracic pressure, we go back to what I was telling you about PEEP, compressibility. So if a vessel is underfilled, it's going to be pretty compressible, i.e. that first garden hose, right? Underfilled. Garden hose is just kind of like cranked up a little bit. Water's coming through, but just like not a lot. You step on it, that garden hose is going to go squish, squish, right? But if I filled it up real well, tanked it right up, you step on that garden hose and it's not going to move too much. I.e., the percent of variation in that hose that's filled, there's not when I step on it. So when the breath is being pushed in by the vent, and the vessels or that volume, that stroke volume, right? It's looking at the heart. I think of like the IVC, SVC area, right? If it's plump full, it is not going to give very much. It's not going to compress very much, which means it's not going to have a big variation inside. The measurement here is a percent. So when you look at the number and see 7, that's 7% variation. If I underfill that vessel and the breath goes in, the vessel is going to go bleh, 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 bleh. That means there's going to be a bigger percent variation. So high is dry, as they say. Makes more sense now. The number, as you get higher percent variation, you are drier inside. You don't have, this is when you look at it and say, they would need more fluid or blood or whatever the thing that's going to fill up the space, right? But the thing that's going to make it so there isn't as much variation within those vessels. So then the challenge is like, what do you use? Well, it's pertinent to what they need, right? If it's blood loss versus sepsis and just needs fluid. But remember this is one number. So oftentimes you have wonky numbers and your patient has 13 is the identified number as a greater than, do you treat your patient, right? But whatever, we never even do that. But like 13 is that number where after 13 you need volume, right? So the percent variation after 13% is you're dry. So go give them a liter of fluid or something. But no, that's one number. If my patient has a variation of 20 and they're mentating and dumping out pee and it's not because they're in DI or something, probably not going to go treat the 20, the SVV of 20, right? That's why we say this a lot, the numbers don't really mean anything and no one really treats it. It's true. It's actually true because you have to put everything in context. Like, you have to learn what everything kind of means, but then you have to do the zoom out thing and look at everything. Like, I would never say a CVP of 13, which is greater than 12, you would diurese, because by definition, you would diurese. No, I might have a PEEP of 20 now. It's one number though, and by definition, that means you're in fluid overload. The SVV of 14% or 20% or something tells you should give fluid. Meanwhile, they're having a full-fledged conversation with their family and they're peeing the best they've ever peed without diuresis, without having an endocrine disorder. So, no, don't treat that, but put it into context. Look at your patient. Are they paler? Do they have paler? Are they looking really mottled and then they're not really peeing? And maybe you can't do the mentation thing because they're sedated and they get crazy on the vent, so I don't want to maybe go that route. But maybe those other signs and symptoms that suggest with the SVV being high, maybe some fluid. Okay, sure. Now you have some other things that you can argue with, but not a number. Like never treat one number. Now, asterisk to that, sometimes there will be one number in something that you come across in a patient that it's the only thing that's off, right? But something inside you, this is nurse instinct, right? You do develop this. I don't know why, but this number is making this, something's uneasy about this one number being off. I don't have anything else to go with it. I can't argue this one thing. Clinically, the patient doesn't look different, but I feel like maybe kind of like the calm before the storm. Like something doesn't make sense. I can't put my finger on it. This one number really makes me like, I'm not feeling it. Something's wrong. Now, I'm not saying give me a fluid bolus or diuresis or something like that, but maybe you're starting to think about something and putting dots together. I don't know. So I like to say never treat one number, but also sometimes you do come across this one thing that just doesn't make sense, you know. And that's where, as more experience comes along, you just can't maybe put your finger on it, but something has happened inside of you to say, I'm watching you. Right? So, what else? Is anybody having any experiences with this? I mean, you asked me what the flow track meant. Have you had the flow track and now maybe seen some of this go hand in hand? Like, I have the vented patient. By the way, who in here, show of hands, has actually had a functional A-line? Nobody got it, right? Ugh. I feel like we need to put them, like, here or something. I don't know. They're terrible. I'm always, like, pulling them back, pushing them in, retaping them. I mean, the patient's literally, like, triple jointed by the time we're done with them because we're trying to get the thing to work. But I mean, I mean that in comedy because it's like, it's true. We see this a lot, right? It's like got to be a blue moon for these things to ever work. But have you had the patient that's got the flow track that had adequate stuff in line and you were able to see these things maybe change? Maybe you saw the SVD and the CVP and the urine was low and you did give a fluid bolus and you saw the SVD then go down and the CVP go up and they peed better. Like, have you had actual practical application of the device other than writing down numbers? Has anybody actually had successful use from the iPad? No.
I know I haven't, just because I feel like I haven't. I think I've only had probably like maybe 4 or 5 of them so far in my career, maybe. But I've always just written the numbers down hourly and just never knew. So that's why I asked if you could go over the the reasons and the numbers. So thank you for that. That was more helpful. But now I'll be like, it'll make more sense if a doctor orders stuff based on those numbers.
Yeah. And, you know, the thing about the flow track is, you know, because all you need is an A-line. Now, actually, let me throw out one more little piece here, because I told you write down 7 numbers, right? And I only like 5, which actually means I really only like, right, wait, am I saying that wrong? CO, CI, SVR, SVI, SV, R, SVI. Is that 9? How many is that? Hold on. So you write, I always write these in order. That's just because of how I remember them. But CO, CI, SVR, SVRI, SV, SVI, and SVV. So you have 1, 2, 3, 4, 5, 6, 7. Okay, right. So 7 identified parameters that you're monitoring. And I don't care about 2 of them because I just don't even think about them. So that leaves me 5, but take away 2 more, Actually, sorry, just one more. One more. Just take away one more. So 1, 2, 3, 4. So there's 4 things that you're going to be able to get if you don't have 2 devices in your body when you want to use a flow track. So if you have a flow track and you have an A-line, that's 1 device, right? So now I get the wave and it gives me information. The problem is if you want your SVR and your SVI, which I don't care about, right? So that's the extra one, the SVR. You can't obtain that information unless you have a CVP. Okay? So for those who don't know, it's MAP, if you want to write this equation down, MAP minus CVP divided by the cardiac output times 80, that's your SVR. We used to have to calculate that a lot back when we used to use swans a ton. So if you are looking for that added information, that is the SVR and SVRI, specifically the SVR, because that's all I care about, then you need a triple lumen at least to get that parameter. So you get your CVP data, so then you can calculate it. Otherwise, you're left with just the other numbers. So you would need some other device to get all of the numbers, but to get those basics like the cardiac output index, the SVV, and of course the stroke volume, you can just use the A-line. So when the flow track came about, because it's a less invasive means to monitor the patient and get some of that same information you would have from a PA catheter, that's hell of a lot more invasive. Then we started to change how we manage our patients. We were using that data. So now we don't put swans in people ever. And when we do, everybody's like, oh, that's the thing that people were talking about. No one knows about it, right? And unfortunately, because of all the things that we aren't able to do with it anymore, you're not left to do much with it. But it's funny because you're supposed to stare at it and care for it, but also be expected to know what the waveform is, but you don't have a lot of stuff that cements that concept into you because you never use it. So how would you feel would you really ever know what a real PA tracing is if you had a swan and know if it was in wedge without it actually being wedged? How comfortable, how confident are you? But you're expected to take care of that patient and know that, or have some degree of expertise around it, or
That's just a foul ass picture to send to them.
I'm sorry, I didn't hear what you said. Oh, sorry, I didn't hear what you said, but
Sorry, my roommate talked to me.
oh, okay, no worries. I just didn't know if you were talking to me. I just didn't hear you. But so what I'm getting at is that long time ago we used swans so much, and now they're so infrequent. And this was the thing that sort of replaced that, as just to get some of that basic information from a less invasive means. Wonderful, right? But then you have all these things that have to line up and make sure it works right. But then when you do get that other thing, you can't wedge it. It's infrequent, but you're responsible for knowing if it's going to kill them, right? So every day you look at it, it's still at 65 sticking out of their body, and you're staring at that terrifying yellow line that's just doing this and hoping that it's okay. And hopefully asking somebody who does know, is this okay, right? So it took a lot. I think that because it's kind of I always use this analogy is cell phones, right? Cell phones made so much stuff convenient, right? You can list a bunch of phone numbers in there, but do you remember really any of them now? If you lost your cell phone, would you be able to call your mom, your dad, your sister, your brother, your friend? I don't know. Some people maybe, but you used to have to actually remember them, right? Now cell phones have made it where if you push a button and you're connected, but I don't really know. I actually don't know how to call my parents because they have out-of-state numbers still, and I don't remember them. I just never can remember them. I can call my old home. But what this has done is like technology, the advantage of the flow track has made it less invasive for the patient to give some of the same means of information, but now it's taken away an aspect of what we used to do. Now, that's in our area, right? You go to CTICU, of course, they're using them still day in and day out. It's part of their norm practice, but for us, it's not anymore. So it's a little terrifying when people have a PA catheter and they're just like, ugh, I don't know what it's supposed to do, what it looks like. So that's where you just have conversations like we are today, and you go to the heme classes and stuff, and just try to keep seeing it. Maybe stop by CTICU and take a peek over someone's shoulders, maybe ask somebody, and just, you know, do obviously your own self-studying. But that those things have kind of changed, right? We don't wedge anymore. The problem I always see with that, not wedging, but just the whole concept of not having the device around as much, is that device back when I started helped me understand drips better, because if I thought this is what the drip should do, and I saw that in their body, and I made a change knowing this should be the next thing that would happen as a consequence to my change on the drip, and then I go make the change, I'm like, it happened. Yeah, like I knew it. I actually knew. I thought this is what I thought. I had that. I figured like the cardiac output should fall. I wasn't quite sure, and then I made the change on the epi, and hey, their cardiac output actually did change. Or I went up on their dobutamine, and their SVO2 actually went up, because that's what I thought would happen, and it did. It's like I don't know. It just makes it stick better, and you feel better, and you're more comfortable around it and stuff like that. So, you know, yeah, we don't get to do anything with it anymore, but we got to have some understanding about it. But those numbers, I mean, you get other numbers from that. And if you also get a manual swan versus a CCO swan, which is continuous cardiac output, and that gives you some live information, so that is better than just the manual, but still you get to just stare at stuff, right? So it's always good to like go over these things, but the flow track, as long as all those things work out, the regular rhythm, the actual working equipment, the positive pressure, if you can take it for face value, you look at that information, and if you see those numbers drifting, like their cardiac output or their index, you can titrate your pressor and still hopefully see the exact same thing as if that was a PA catheter, right? If I had a low index and I was on epi and I went up on it, I should expect that index to go up, because the cardiac output should go up. So therefore, I'm going to go from 0.01 to 0.02, wait a little bit of time, stare at my machine, and holy shit, the cardiac output went up and my index went up. Oh, and by the way, they're a little less modeled. Right? Like, oh, whatever. I have this one, which is rare. Should I get it done a different way so I can see it? Yeah, exactly. That's the thing that terrifies people is, you know, when you are expected to know what the yellow line should look like, and then knowing if they have valvular disease and they have something like mitral regurg, and now they have prominent V waves or Canon V waves, and then it actually wedges itself, but it looks like a PA tracing, and then you leave it, and then they infarct and die. I mean, like, who doesn't want to? I don't want that to happen. So but having not a lot of experience with it, which is very, very limited these days, makes it even more. I mean, it was terrifying when I used it every single day, and now it's like a year would go by and I might see it, and you're like, ugh. So if I'm having my sphincter pucker, I can imagine how you feel when you've like either never used it or used it like one time, right? So I'm with you. It's makes you a little bit, a little scary. So, but FlowTrack is like your phone, right? It's made it more convenient, therefore more accessible and less invasive, but now you kind of forget some other stuff over here. So hopefully with, like I said, you know, just classes and stuff and trying to at least bring that stuff to the surface, you have that, have some concepts of it, you know, so that when you do see it, you're familiar with a little bit. And every time...
Mark,
Oh, I'm sorry.
No, go
Have
ahead.
you ever seen a pulmonary artery rupture from a swan?
Okay, yes and no. So no being I haven't witnessed it happen, but yes, I took care of one. So this was probably, I think, like a year off my own orientation, maybe a year and a half. And for those who've been around a long time, Mark Napier was like still a fellow, and because I remember him calling him directly. There was a patient. So hopefully people who have taught you tell you that every shift you should run strips, right? Do your EKG. If you were to have a SWAN, a CVP, those need to be identified every shift. With a PA catheter, even more so. Triple lumen CVP, okay, like, yeah, get it on paper somewhere, but like if you have a SWAN CVP, a little different. It's supposed to still be the same CVP, but I have a device in your heart, not just like somewhere over here near your heart. It's in it. So I want to know if all those things look okay, right? So I need to identify the waves. Well, there was a patient who had an MI, I know, I just don't know any more beyond that. I can't remember much about this. This was so long ago. But there was a patient who was in CICU who was up eating breakfast and had their MI, but like had the SWAN still in him. And the nurse who had them never ran strips and went in and wedged the patient to get a wedge pressure and never identified that the patient was already in wedge and tore apart the PA. The guy started exsanguinating. So, of course, they call a code. And I don't know the name. I always have to ask like someone like Patty Lurwick or something. There's a device. I describe it as a rigid Foley, right? So it's a long tube, like a Foley, except rigid, not flexible. And it's got a balloon at the end. And what you do is they intubate, and with the bronch, they drive this thing down where you're squirting in blood, and they blow up the balloon inside to sort of tamponade from the inside and push against the walls. Then they rush them immediately to IR to coil the crap out of them from the inside. So I get this patient after that. I never had that happen to me. So no, I never have seen a patient actually rupture in front of my eyes, but I have taken the post-rupture. And I've only had one. So it's not happening frequent, but you never want it to happen. That should be one of those never events, right? Like, never want that to happen. So I don't know what came out of it. My patient lived. I will tell you that. I will tell you a funny story, though. So that was my patient. I wouldn't even... I don't know if I blinked that shift. I was freaked out. Like, I was just like... Because this thing is laying in their mouth, right? Like, they've already been coiled, but, like, now this rigid Foley thing is, like, sitting in their airway, like, down in, and I'm like, okay, and it's not supposed to move. And I'm, like... very gently turning my patient, and I don't think I ate a lunch, nothing. I wouldn't even leave the cubicle. If I had meds, I'd be like, hey, can you get me that over there, like, real quick turns. I was nervous, right? And then as like so meticulous as I was that shift, I think it was like 8 hours in, and I did my like really like whoop little turn, and the thing went it moved, and I was like, ha! I might have actually crapped myself then there too. I immediately call Dr. Napier, and he goes, "Oh yeah, he was coiled. He should be fine. Like no big deal." And I'm thinking, I wish someone made it sound like that at the beginning of my shift, because I think I developed my own ulcer, which led to my GI bleed, which, yeah. So it's I've had one, and it's intense. It kind of reminds me of the Blakemore tube, but for your airway. If anybody's familiar with that thing. Oh, speaking of GI bleed, Blakemore tube. Guess I never covered that. Just so you know, there is one kit in the institution. It's like in a tackle box. It's called the Blakemore kit from CSD, and it has a giant tube in it, and it has a couple balloons. One is to inflate the sausage link that lays within your esophagus. One is to hold a distal balloon so that it can't get pulled out. And then you anchor it. It used to be by a football helmet, but CMS thinks we can't clean them. So now what you do is you tie gauze around 2 liters of any type of solution. This is where any solutions will do, because they're not going in the patient. They're your counterweight. So you tie the Curlex roll to the device, and then you bring it over. You know how like if the IV pulls on the back of your bed, you drape it over that and then tie the other end of the Curlex roll to the 2 liters of saline, so it just hangs. And that's holding that whole device up. So that's for esophageal varices. Put in by GI. See? It's good we talked about this, because Nat talked about that. Isn't that how funny medicine is? So we're at the tail end. We got a few more minutes. We can end early. I just don't know if anybody has any other questions or anything we've just gone over, or any last minute anythings. Do we have a date for the next one? Yes. The next Q&A, unfortunately, only time I can do it is while I'm on my vacation. So I am going to do that on the 7th of January, also 9 to 1. I think the time seems to work for everybody. It's like not bright and early, and people who are getting off on nights might be able to come. And like I said, I want this to always be just a very like casual, like if you can come for a little bit, come. If it's, come at the end, come for an hour, come for the whole thing. Bring your mom, bring your dad, bring your pets. Bring your pets. Love the pets. But just, I want it to be comfortable. We don't have alarms and families and all that other stuff, PJs and Coco and all that. I just want it to be very calm and, the best experience I can provide for you guys. So yeah. So any last minute anythings? Is there a vent Zoom? Yeah, so I am doing the vent class. As far as I know, it's still only everything is still like Zoom. So I will still be doing the class, but it will be just like this. But it'll be the vent class, and that's the 15th. Yep, that's next. I don't even know. What is that, next Tuesday or something? Right. Yeah. So next Tuesday, same thing, 9 to 1. And we'll cover a lot of the things I just did here, but obviously more in depth, a little slower. We'll talk about some modes. Can CNAs go to the vent class? Any chance that can be recorded for those work? So I'm literally right now trying to figure out how to record this. I downloaded a program, and I'm gonna see if it works. And then I created a YouTube account to see if I can upload it. I'm hoping it works, and then if it does, I'm gonna also put any of that information that I've found out from previous questions that I felt like I couldn't answer, and do sort of like just a quick video, like, hey, you asked this, this is what I found out, and just kind of throw it there. That way, if someone wants to see it whenever they can, especially if you can't come back to maybe the next one, I just don't want it to feel like it was just an open-ended question and just like, yeah, whatever. Because also, again, it is a two-way street. I'm learning from what you guys are asking.
Also, there's a record button on like the bottom of the Zoom thingy. And I've tried clicking it last time because someone wanted me to try to record it.
Yeah.
But it says, please ask the host to give you permission to record. We could always, I don't know if that's like you or if you wanted to do that.
Well, so Alana gave me the host, and I'm not that great with this program yet, but I actually made my own program this morning, and I think that there's a space limit. So we're going 4 hours, and I think it goes to a gig, and 4 hours is probably more like almost 3 gigs. So I think that recording is more like these half-hour type meetings rather than a 4-hour session. But what I did is I downloaded a program, and it's running right now, and fingers crossed I get it to work. I don't know. I've never done this before. So you guys could be the first. You guys could be famous. And then as far as if the CNAs can go, like I don't care who goes. I just can't say that you'll get paid for. That's a manager. You know, obviously this is for nursing that are going to take care of patients. But could you go? Sure, I don't care who goes. It's more of the do you get paid to go part. I don't think you would, but
Yeah, for CNAs, I don't know. We've planned the next 4 classes that Mark is having, and they just sent out the newest Scoop newsletter, and they just revived that, and Kristen Stogsdill and Jess Purnell just sent that out, and it has all of the meeting IDs in there.
oh, nice.
So you've got them, and I'm trying to make them like events on our Facebook page so that people can see, and I just invite everyone. But for the CNEs, PCTs, I don't think that you would get paid for this time, but it would be beneficial if you're in nursing school. I think that's, sorry, I was down getting lunch.
Oh no, no worries. No, that's I appreciate the link in the Facebook because the reason I think a lot of people after the first one liked I think that notification. I think they get that communication a lot, so they appreciated that.
I know, that's why I know it's super unprofessional, but it's the fastest way I can reach you guys is through the Facebook group because I know people will see it and tell people who are not on Facebook,
Yeah.
and it just gets
no, that's why I asked for it because I think a lot of these guys were like, that's a really good way to get everybody, especially just hitting the link.
I have a quick question for this meeting. As a CNA, are we supposed to email managers our time, or does it not count for this one either?
I don't know. I would try it. I don't know because we didn't ask beforehand, so I would email and ask.
Okay, thank you.
Well, I'm glad you guys came too because you see some stuff in nursing school that maybe you don't cover or in depth, or they leave stuff out. The infamous QRS complex. I won't talk about it right now, but those who have heard my spiel about that one. So yeah, the dog. I'm just, man, look at that. Oh, love him. Just want to give him a big
There's free dessert today at work.
What's that?
There's a free dessert box at work today if anyone's coming in tonight.
Of course, and I'm not there. Probably don't need it. I got pandemic fat going on.
We all have pandemic fat, and I had to buy new pants.
Well, if
I'm gonna
anybody,
get tested.
if no one has any other questions, then it's a wrap, I guess. I'm really happy you guys came. A successful Q&A again, I think.
Yeah, thank you, Mark.
Yeah,
Thank you so much, Mark.
no worries. Happy to do it. All right, guys.